Yep.
Okay, could I ask those of you who presented this morning, including all 10 of you, there's actually chairs in the front row or close to the microphone would be great. We are going to spend about the next hour, but time as needed, discussing with the presenters some of the issues we're focusing on. After that, we're going to have a discussion amongst ourselves, still in public, and then proceed to voting. So in the spirit of openness, although questions will be asked to specific ones of you in most cases, or maybe all cases, I generally have the view that if somebody has some of the presenters has something to say that is on point to the question, I invite you to also answer after the person who's been asked has offered an answer. I don't want that to become kind of out of control, and so we'll manage that, and I ask you to stay concise and on the question at hand. But I think we can get started, and so I guess I will open the floor to the panel. Anyone from the panel can ask a question of any of the presenters, and of course, as a presenter, you are free to pass if you don't want to offer an answer. Please, Roger. And panelists, please reintroduce yourself when you ask a question, mostly for the recording.
My name is Roger Lewis. So this is a question I think is directed probably to the first two presenters. And it has to do with the use of the definition of an adequate trial antidepressant.
Roger, hold on one second. I'm sorry. I don't think. Can you hear?
The gentleman's coming right now.
Okay, no, I think we have an AV problem. Oh, you have to turn it on. There we go. Okay, Dr. Lewis.
Take two. My name is Roger Lewis. My question is directed to the first two presenters primarily. It has to do with the incorporation in a possible definition of treatment-resistant depression that includes an adequate trial of a pharmacologic agent, specifically in an elderly population that may have a decreased ability to tolerate that agent. So it strikes me that using an intention to treat philosophy, that if a patient is unable to tolerate the usual dose of a medication, that it's not clear to me that from a clinical perspective it makes sense to discount that as in counting the number of failed trials. I'd like you to comment on that.
Before you start, can you clarify what you mean by discount?
So if one considers a possible definition that counts the number of failed trials, it was my understanding that a trial in which the patient failed to be able to tolerate the minimum dose that might be used in a younger patient, that trial would not be counted. And to me, that seems to violate an intention to treat principle that might affect the definitions as applied to an elderly population.
So, short.
Is it the bottom?
Oh. Does this come out?
Oh, yeah, here, use this one.
Marie, you want to use this one?
Here, you can use this one, Marie.
There we go.
Maria.
I'll pick it up.
So,
I got it.
so
We'll share.
So, short answer is yes, intent to treat analysis should include everybody, and therefore if you're doing an efficacy trial, you should include intent to treat analysis to assess efficacy, side effects, anything you want. For the purposes of defining whether somebody has had an adequate exposure to an antidepressant for it to have had an adequate trial, this definition is really designed for that. And in that case, if you have a patient who is unable to tolerate 3 antidepressants one after the other after taking the first dose, and you want to call that an adequate trial, would actually kind of doesn't match with the way we think of treatment resistance. So it is conceivable that the patient has that physiology that gets you there, but then you have to redefine for that patient how to call that. But if you don't have adequate exposure, then you've not had an exposure to a treatment for it to work. So that's how, because it's not designed for intent to treat analyses, and that's not the purpose for defining this.
May I follow up?
Absolutely.
So I understand completely the philosophy from a pharmacokinetic or pharmacodynamic point of view, but I'm trying to envision the operationalization and the clinical application of one of these criteria. And I envision any future definition of treatment-resistant depression as being a potential gateway to coverage for alternative treatments. And if an elderly patient, for example, was unable to tolerate 3 medications in a row, as a non-specialist, it seems reasonable to me that the clinician may want to have access to a different mode of therapy.
Yes, please. If you'd like to speak, you just come to the microphone, and I'll recognize you. And again, could you also state your name simply just for the recording?
Harold Sackheim from Columbia University. When we developed the approach for evaluating treatment resistance, this was actually a very important question. Did it matter whether the patient met dose and duration criteria? Was that particularly predictive, or did it matter that the patient got exposed to the drug? Was it more important to count the number of total trials that the patient had, or just those that were adequate? And that's been looked at several times in literature in terms of predictive validity. What does it tell us about what's going to happen with the next treatment? And it's only the number of adequate trials that has the greatest power in predicting the next treatment. Now, in terms of, so that's the scientific justification. The practical or clinical view is, of course, if somebody, an elderly patient, has difficulty tolerating a number of trials, you're going to go to something else to treat them. That's not going to restrict necessarily what's available for their treatment, but we wouldn't necessarily consider them treatment resistant.
Could I just ask, Harold, don't leave for a moment yet. May I follow up on that for a second?
Please, just proceed.
For people who
Please
have
say your
not-
name before you ask.
Will Carpenter. For people who have not had an adequate trial, do we know how likely they are to be responders? So it's not the strongest predictor, but is it a weak predictor, moderate predictor?
For across brain stimulation and pharmacologic treatments, patients who have not had an adequate trial do far better than patients who have failed one, and certainly better than patients who have failed 2 or more trials. So in a number of recent studies, for instance, the inclusion criteria for the TMS trials, the 2 major ones in the United States, allowed in patients who were intolerant of medication or who had proven resistance to medication. They allowed both in. And those who were intolerant did better.
I don't know if there's other questions. I actually think that follow-up answer also addressed your question, Roger, that there does seem to, I think the distinction, let me try and put a point on it, but please anyone correct me if I've got this wrong, that their resistance to treatment is, if you will, an indirect measure of the disease, and intolerance of treatment is, if you will, a fairly direct measure of a patient's ability to sort of take the medication. And so that categorization seems to comport with what you just said, which is that condition on those 2 different ways of getting into a trial, the outcomes are different. So we are faced with the term treatment resistant, but as we've discussed before, we can consider what that means in the context of answering these questions.
Cuyjet, I have a question related to, I'm going to put my internist hat on for the moment. I know we're talking about treatment-resistant hypertension, but in a Medicare population, if you look at the incidence and prevalence of high blood pressure, diabetes, joint disease, glaucoma, and the chronic conditions, and now we're going to add in a couple other medications to the mix where polypharmacy is already an issue. I just have a general question in terms of drug-drug interactions, side effects, and is there any general experience how you fit that into the mix, looking at the patient as a whole entity? it's problematic. So
This is Brad Gaines.
Well, I was just
Maybe-
an open
maybe
question.
I'm wondering about another way to maybe phrase that. It sounds like what you're saying might be, and again, correct me if I'm wrong, it might be have concerns about drug-drug interactions affected your pharmacologic recommendations for someone with treatment-resistant depression. Is that kind of what you're also saying?
kind of, yeah. But out of the two initial presenters, or anyone else of the presenters, feel free to respond.
Matt Rudorfer, NIMH. I say the move from the tricyclics to the SSRIs have probably proven helpful in that regard, in that the SSRIs tend to be easier to tolerate, come with fewer side effects. I think it's fair to say that many clinicians will look to drugs like citalopram, which was the stage 1 and STAR D, as having relatively few drug-drug interactions, and usually mixes well with meds for physical illnesses. I think at the same time, research has shown that specialized forms of psychotherapy, like the CBT and interpersonal therapy we spoke some about this morning, have merit as a first-line treatment for many people with depression. And again, that would avoid the issue of adding more drugs. And of course, as we've been saying, at the more severe end of the spectrum, historically that's been one of the roles of ECT in terms of a non-pharmacologic intervention which is done under controlled conditions so that even the frail elderly can be safely treated.
Chuck Conway from Washington University, St. Louis. I think along the same lines, one of the issues with regards to polypharmacy is that some of the treatment-resistant population that we've studied, many of these patients have been on a series of medications, in fact, oftentimes from the same class. So you see, for example, someone who's been on 5 SSRIs in our database of over 150 patients with treatment-resistant depression. Based on what was happening to these people in the community is that they're getting the same medication classes over and over again with the same outcome of failure, 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 failure. So I think the evidence as was presented today, and perhaps this wasn't emphasized enough, because we were talking more about treatment-resistant depression rather than the treatments for it, but there is evidence, pretty good evidence, that some of the more novel treatments, like stimulation treatments, perhaps the NMDA antagonist treatments, and also the vagal nerve stimulation, that the effects of these devices is much more long-lasting. And in some ways, I think the issue of compliance with treatment and the issue of interactions with drugs is removed from the equation. So I would argue that there's evidence that there does come a point where you need to use something other than just the existing treatments, and that's where I think there are advantages to these novel treatments. Many of these novel treatments are very clean and very safe. So.
Doctor, actually, can I ask a follow-up? So if I'm misremembering or misapplying a statement to you that someone else made, I apologize. I thought I heard at least this morning that the number of different treatments was a factor in considering treatment, but the categories of those treatments, we're talking about pharmacologic,
yes,
should not be considered.
Well, I think the general consensus is that from one category to another, that there is no definitive evidence that one antidepressant class is superior to another. But I think the general practice in treating depression is if you try a medication, for example, if you try an SSRI and that fails and the patient doesn't respond at all, then the next drug you would try would be something like a dual reuptake inhibitor like duloxetine or Effexor or something like that, or Wellbutrin. A different neurotransmitter system would be targeted. That's sort of the standard of care. There is some evidence that if you fail one SSRI, a second SSRI does sometimes work. But I think this repetitive giving of the fifth SSRI after 1-2 hasn't worked, that's going on in the community right now in the geriatric population. And you're right, the polypharmacy issue is a huge one in this population. That's one of the things that these devices, so the devices and some of the newer treatments don't, they take that out of the equations.
So you would consider somebody who's failed 2 successive SSRIs as different from one who's failed 2 different classes of drugs in terms of whether or not they qualify for treatment resistance?
I would, yes.
Okay.
That would be my recommendation.
Thank you.
I'm
there was
sorry,
another-
just, I want to be sure I
Yes, there's a
understood that
follow-up.
answer.
All right, hold on. There's a follow-up comment. Go ahead, please. And then Dr. Carpenter.
So 2 points.
Then
One is,
next panel.
I think this issue of polypharmacy and drug-drug interaction for the elderly is a real issue and a real difficulty, and that should be seen as an issue that we need to be dealing with in the medically frail as well as the elderly, no matter what. And it is not a unique treatment-resistant depression problem, in my view. There is one component of it which may be, and that is some of these patients, after they've had multiple treatment failures, may end up on combinations, and therefore it enhances the risks for drug interactions. Going to the SSRI, SNRI question, I think it's more complicated. So in STAR-D, when we switched them from one SSRI to the next SSRI and compared that to an SNRI, the dual mechanism agent, or bupropion, there was no difference. And so therefore, at least in our study, our hands in that study, going from one SSRI to another, or SSRI, or said it differently, going from an SSRI to SNRI was not superior to going from an SSRI to another SSRI. What ends up happening is clinically, so to speak, a little more medical logic, and that is if you have tried an SSRI and another SSRI, does it make sense to go to a third one? But data-wise, we don't really have anything profound that tells us you have to go to something different. So to your answer to your concrete question, categories probably doesn't matter if you have had multiple treatment failures.
Thank you very much for that. Dr. Carpenter?
That answers what
And
I was
actually,
going-
we'll pause.
Oh,
You know,
no,
it'll
Carpenter.
make my life easier if you guys put up your tent cards if you are waiting to ask a question, just so I don't lose track. So go ahead, please.
No, I think that answers the question, whether or not the different class made any real difference in this. And at least in the field I work in, the blinded switch to the same drug seems more effective than the blind switch to another drug. Slight evidence for that. But I think that answered my question. The other thing that I was going to ask is a change of subject. Can I go ahead and change the subject on this?
Absolutely.
So,
Within the bounds of the topic of the MEDCAC.
yeah. So this is in the criteria for treatment resistance. Cognition impairment is not there. And I wonder what is the role of impaired cognition in thinking about treatment resistant depression?
Do you have a specific presenter you'd like to answer that question?
Treatment of depression is a big issue in our field now in general. The FDA is struggling with how you think about depression, cognition as an indication in depression. In some circumstances, like schizophrenia, premorbid depression is a predictor of the longer-term course, maybe treatment resistant. And I just wondered why that pathology is not among the things that's defining treatment-resistant depression.
Harold Sack, I'm from Columbia again. Thank you, Will, for that question. There are many aspects of depression that are reflected in dysfunction. And it's quite clear, I think, that major depression, and in particular patients with treatment-resistant depression, have cognitive deficits. We've been able to show that in the longer the duration of episodes in bipolar disorder, the more severe effects you see on memory functioning, for instance. But the definition itself of treatment resistance is in many ways independent of the clinical characteristics or the manifestation of the depressive illness itself, which can be quite heterogeneous. There may be suicidality, there may be not. There may be cognitive impairment, there may be not. But fundamentally, treatment resistance pertains to the patient's history of failure with particular treatments, lack of benefit from treatments. And that, I think, makes it crystal clear, so to speak, what we mean by treatment-resistant depression, and leaves it open what the manifestations of depression may be itself.
If I can restate that answer, are you saying that other related conditions do not modify the definition of treatment-related depression? They may change the probability of it, but you don't incorporate them into your...
Right, and to the exception that if it's a misdiagnosis of depression, it's really an occult medical illness that's presenting, quote unquote, as treatment, then we wouldn't consider that to be treatment-resistant depression. But within the diagnostic category of major depressive illness, it's the history of treatment that defines whether you're treatment-resistant or not.
Thank you very much. Does any of the other presenters have a comment on that? And then Dr. Ohlendorf is next, I think.
Scott Aronson, Shepherd Pratt. Just further along that line of thinking is I think that the development of new tools to assess severity of depression sort of goes in line with what medications we've got. So a couple of medications that have come out on the market. So there's a new medication called vortioxetine that a lot of the clinical trials have included doing cognitive testing because they believe that that medication may help cognitive testing. And as well, some of the device-based systems have included cognitive testing as part of the general screening for these folks. But it really has only come into play as we think we now have different means to improve cognition within folks with depression. And cognition is part of a MADRS scale, includes concentration as one of the parameters. So we've got a crude measure there.
Thank you very much. Dr. Ohlendorf.
Yeah, thanks, Dan Ohlendorf. So I'm thinking about operationalizing the definition as well. I'm thinking about it more broadly than just clinical research, though, because ultimately CMS has to possibly use this definition as a pathway to coverage decision-making, but then also tracking and monitoring, and I'm concerned about some misclassification issues. So several of the clinical researchers talked about pseudo-resistance. What is your sense of the magnitude of this issue? I'm assuming it's pretty big because adherence is an issue across all medication classes for all conditions. I'm also thinking, and I don't know if there's stratification that's sufficient enough to try to understand performance in the entire group of non-resistant patients versus the subgroup that is not resistant because they never got to an adequate trial of drug. So obviously non-resistant will include those who are being successfully treated. So if there's any information on that, that would be important to know as well. Then the second part of my question is really for those in the patient community. What are the challenges in actually getting through an adequate trial of an antidepressant? If you've got disease that's really causing you problems and affecting your life, are you actually able to get through an adequate trial in terms of duration and dose? So I'd love to hear thoughts on both of those levels.
So the rates of pseudo resistance, actually the data are a little less sort of mixed. We don't have large scale long-term follow-up cohorts where we can officially tell. There's very good evidence that in primary care, of the people who start an antidepressant, only half of them actually get just minimally necessary HEDIS requirements met for patient treatment, adequacy of treatment, suggesting that the other half do not potentially have adequate dose and durations and could then come back. The patients may come back in 6 months and then be seen as having failed to respond to one trial, which is now pseudo-resistance. So we have that kind of indirect data, but that gives you the scope or the magnitude of pseudo-resistance also.
As a follow-up to that point, Chuck Conway from Washington University, I think it's important with thinking about your question, that it's what Dr. Trivedi was talking about was the vast majority of people, I think it's estimated around 90% of antidepressants are prescribed by primary care doctors, not psychiatrists. When you get to what we're talking about today, more the resistant population, those patients, I think, they're not immune from pseudo-resistance, but I think that this is why I think when we talked about how would this best be, when operationally defining it, how would it best be studied, I think having centers of excellence or centers with expertise in treatment-resistant depression is really critical, because what centers like the one that I'm part of, we actually dissect very carefully what the patient's history was. Obviously, it's very difficult to prove if a person's compliant with a medication. You can't be at their house making sure they're swallowing their meds, but you could tell by pharmacy records, you can tell by the patient reporting to their physician at each visit. So I think when you look at it from an operational definition for research purposes, it does. I think that the pseudo-resistance numbers that have been tossed around are on the high side when you look at it from a research perspective. So.
Charlie Donovan, patient. When you have TRD, you are in a war. It's a battle. And I could just speak for myself. I never missed a medication, followed the directives of my psychiatrist, and I would do anything, whatever it takes to get better. Try as many medications, combination, augmentation strategies. I mean, you have to put up your fists and realize you're in a fight for your life.
Eric Scharf with DBSA. And I assume when you used the word trial, you meant adherence to different types of drug, not a drug trial per se. So, and in my experience was that I tried many different medications. There's an NIMH publication called Mental Health Medications, I think it's called. And in the back, there's a whole list of all the different medications. And I went into my last psychiatrist and just checked off all the different things. I couldn't remember why some worked and some didn't, but I was able to just go through that. It was actually, at DBSA meetings, we hand that book out now and tell people that's a great resource to use. But it is challenging with so many different medications out there for people to try. In my case, I think it was, again, sort of as he was referring to, you make those efforts. My experience, though, and listening to folks from the support group that I facilitate here in the DC area, there are many folks for whom either they are resistant to the idea of taking a medication. They've tried some, and some didn't work, and so they decided none of them are going to work. They face some of those kinds of challenges. So it's understanding, that kind of thing. The final thing I'll just say is I don't know the exact percentage. Obviously, some CMS expert here knows the number. People who are in Medicare program obviously are overrepresented. I mean, mostly senior citizens, but the mental health component of those on disability is very high. And so I wanted you to keep that in mind. That it's not just senior citizens, but it's folks from a wide spectrum of ages. I am not a senior citizen yet, so thank you.
Okay, Al Syrek, I'm going to ask a question, and then next question will be asked by Dr. Cruz Flores. My question is go back to the initial definition of TRD. Now, we've heard unipolar, bipolar, atypical, and psychotic. One presenter, I forget whom, suggested we ought to restrict the definition to unipolar. Others suggest that we ought to include other types of depression, treatment-resistant depression, under the umbrella of the definition. I'd like some feedback from the presenters in terms of what your opinions are in terms of an exclusive or exclusive definition, because it seems when you have 4 different types, it's a syndrome that's related, but they're not all the same. So should this definition just include treatment-resistant depression and unipolar depression, or should it be inclusive of other types?
Sackheim again from Columbia. I think some of the confusion comes from the fact that we have evidence that different treatments may be effective for different subtypes. A good example is in psychotic depression, which can occur with bipolar or unipolar depression. The evidence is extremely compelling that antidepressants alone are pretty much ineffective and that you have to combine them with antipsychotics. In fact, in relation to the previous question about tolerability and can people take the drugs, when we examined psychotic depression in a large multi-center study, only 4% of patients with that condition met the ATHF criteria for having an adequate medication trial before coming to ECT, because the dosage of antipsychotic that you need was so high that elderly patients in particular couldn't tolerate that. Now with the change in medications and the second generation antipsychotics, the atypicals, we see many more patients who are able to tolerate the antipsychotic plus the antidepressant, and they're considered now treatment resistant. So it's one thing to say, yes, we have one set of criteria for unipolar non-psychotic depression, but when we come to evaluate drugs like lithium or the anticonvulsants, we treat them very differently in a bipolar disorder than a unipolar disorder. So one's criteria for what constitutes treatment resistant should have differentiation of depressive subtype in line with the evidence for the efficacy of particular interventions.
Okay, that's one response, but somebody did say we should just say unipolar, so.
If I can follow, I'm next, right, you said?
Yeah, I was just going to follow up on the original question. Is there another opinion regarding the definition of TRD?
I think it's not entirely different, but what I think is in order to sort of describe, clarify, and use a targeted definition, at least we have to be thinking about each individual subtype individually. So unipolar depression, 3 treatment trials, 4 treatment trials, when we are talking about, is a different construct than for psychotic depression or bipolar depression. So I think that we can debate about whether each one has to then have its own categories, but at least unipolar depression has been more well studied.
Okay, Dr. Cruz.
Great. I have just Salvador Cruz, from neurologist. Follow-up question to that: if there are heterogeneous groups, and certainly all of them require treatment, what is the size of the problem? I mean, if we're talking about 30,000 people in a year that have TRD, what is the proportion of those that are unipolar versus psychotic versus? So that would give us a better sense of a focus or try to homogenize the groups and so on. That's just a follow-up question, and I have another question.
Chuck Conway from Washington University. I think, as Dr. Trivedi said, I think it gets very complicated when you start talking about bipolar versus unipolar. By far, the majority of patients who have resistant depression are unipolars. And the percentage of patients with unipolar who have psychotic depression is very small, probably estimates around 10%, 8 to 10%. And sometimes the psychosis can be very subtle. In terms of the percentage of patients who have bipolar resistant depression, that's even smaller. That being said, I think where the story I think gets complicated is that there is a significant subset of patients with bipolar disorder who have treatment resist, who the majority of the time that bipolars spend with their mood dysregulated is spent in depression. It's like two-thirds of their time where their mood is not euthymia or feeling well is in depression. And many of these patients with bipolar disorder actually do respond to the same novel treatments as do patients with unipolar depression. So this is what I mean by the story gets complicated. So from my standpoint, I think the group that put together the white paper for this conference, we feel that given the current evidence, if we're going to use the model of a series of medication failures as the definition, empirical definition of treatment-resistant depression, I think it should be based on the existing evidence, which is unipolar. But I think that's not to neglect those individuals, because there are many of them with bipolar disorder that's treatment resistant too. And I worry a little bit about that because I don't want that population. That population also needs the same level of attention and aggressive treatment. So.
And then my actual question was, has to do with, I wonder about the definition, and this is for you or anybody else. If we say, as was presented, I gather, and I don't know the whole literature, just what you guys presented. So on the one hand, it seems like it's a big problem. We have this definition that you need to fail trials with good doses. And so, but as I see and what we want is really sustained remission, right? So if from the presentation from Dr. Sack says that the acute remission is at level 1 is 36%. The probability of remaining at 12 months is about 70%. And then the probability of sustained benefit is about 25%. When you go to the tier 2, which is still part of the, you still have about 30% response. The probability of actually of being in remission at 12 months is less than 50%. And then it falls half as many when you go to sustained remission. So the question is, why do we have to wait for 2 trials? You guys have a sense that, or information or evidence or clinical trials that show that, that comparing the course of people with 1 failure and then ECT or VNS or whatever else versus 2 trials plus those added therapies and see what the success is, because what everybody presented is the sustained remission is much better with ECT or with some of the other therapies. And so I just wonder, and if you consider that you're in a population that is older than 65 and with the problems with adherence and then the pharmacological interaction and so on. So any sense, input that can help us?
Two points. One, the magnitude of the problem is frightening in terms of the demographics that we're talking about. 1 out of 5 Americans are going to have a major depression in a lifetime. That's 20% of the population. Our estimates and the general agreed upon notion is that at least 30% of those individuals will have treatment resistance. So that's that we're talking about, conceivably millions of people, not a few. And so the definitions that you propose and ultimately accept are going to be very, very important in defining who that is. 2 may be conservative, but the 2 failed trials notion, but certainly by the STAR-D data, you fall off the cliff after 2 failed trials. The likelihood of sustained benefit is less than 5% at that point. So that provides a empirical cutting point. It also, we're not just, for instance, in epilepsy, there's been a debate whether 1 failed trial or 2 failed trials justifies surgical interventions. This is the same type of question that's being asked in depression. And because it's in part of judgment, there's always some judgment that comes into account when you're determining the adherence of the patient, the outcome of the trial. Was the dosage adequate and so on, then it's certainly a more conservative statement to require 2 than just 1. The other conservative aspect of this and trying to be certain when you call somebody treatment resistance is we're only talking about treatments in the current episode for the most part. It's another large question because patients may have failed many treatments in the past. Are they relevant to the definition, or are we only looking at the current episode? All of the data, certainly that I presented, and most of the data we have in the field, pertain to the characterization of treatment just in the current episode of depression, because it's so difficult to determine adequacy and dose and duration and so on for episodes that have occurred in the past.
Great, thank you. Do you have a fairly, we now have a backlog, so be concise.
Sure. So 2 very...
And I'll ask the panelists also the questions are concise.
Sure, 2 very concise points. So one is, I think, this question of 2 treatment failures and sustained effect or sustaining wellness for a longer time is more complicated than just pharmacotherapy. So there are other factors. And the second issue is when you raise the question of whether something else would be a better option, something else has to be shown to be better than this, and that's not been shown consistently.
Thank you. I've done my best to keep track. Dr. Pope.
Can I ask, too, if they're short, narrow, and focused?
Yes,
All right.
Both that would be terrific.
Thaddeus Pope. For Dr. Conway, I heard you emphasize several times the importance of centers of excellence. So I'm wondering if you could address directly one of the voting questions, which is whether or not a TR definition could be applied only in general psychiatric settings or only instead in specialty psychiatric settings like WashU.
Chuck Conway from Washington University. Yeah, I think for the purposes, this is a question that I think we struggle with. What would be, from a research perspective, I think, and I think that was sort of the focus of the meeting, operational TRD definition for research. I think for novel treatments that are evolving, that many of which are rather invasive, like deep brain stimulation, vagal nerve stimulation, that kind of thing, I think because there is significant risk involved with these types of, or not significant, but there's more risk than taking a medication, that I think that it's probably more reasonable and safe, and probably going to get better findings if you have centers that are specialized in recognizing and treating severe ends of the spectrum with resistance. As it perhaps further down the line, when we get to what Medicare is going to fund, or what Medicare is going to accept as reimbursement, I think that might be obviously we can't do centers of excellence for every treatment for treatment-resistant depression, but I think for the purposes of research, that's the way how we see it. So.
Were those both questions, or?
Yeah, real quick, Thaddeus Pope. So, and I guess this is for the first two, directed at the first two speakers. So the weight of the literature suggests that the definition is the failure of 2 trials at adequate dose and adequate duration, and I guess maybe given the prior discussion, trials in 2 different classes. But the literature and even some of the presentations indicate that ECT is very successful. Now, it's less successful after you've already failed, but it's still very successful. So my question is, could you address why not include in the definition not only the failure of the 2 trials, but also the failure of ECT? No, so it's not just treatment for TRD, but it's built into the definition.
It's to one. No, it was to one of you two. So.
Matt Rudorfer, NIMH. Well, I think the short practical answer goes to the map of the U.S. that I showed this morning, and that is in many areas of the country, ECT is simply not available. There are many practitioners who don't have access to it, even if they wanted to refer somebody. And so as a practical matter, there are many people for whom ECT would otherwise be clinically indicated who simply don't have access to it.
Yes, please, Dr. Trivedi.
I think my plea would be exactly that, is that there's so many places in the country that ECT is not only not available, but it is unwelcome. There is a lot of social, political, media stigma about it, so that therefore if that becomes a threshold question, we will deny the very existence of treatment resistance for millions of patients. I think we have to be careful of that.
Thank you for this. And we now have 3 categories. We have treatment resistant, we have treatment intolerant, and we have system intolerant as the definitions. So one clarification, the reason I stepped out, just to make sure, and I take some blame for this, question 3, because there's been a lot of discussion around kind of the applicability of the clinical research criteria into clinical care. It's an obvious issue, externalization, if you will, or what do you want, whatever you want to call it. Question 3 is a question about clinical care. So it can be interpreted as, if intermediate confidence greater than 2.5 is noted in question 1, how confident are you that this definition can be applied in the clinical care of Medicare beneficiaries? So as you're asking these questions, this is of course an umbrella issue around research, but that is a question that will be useful to CMS to get an answer to. And I'm up to question of clarification, Dr. Gaines?
Yes,
to me?
actually,
okay.
Yes, to you. So for that one, you talked about clinical care. Does that mean clinical care in terms of the identification of treatment-resistant depression, or is that clinical care in terms of the management?
I would say my read is that it's a definitional / identification issue, not a management issue.
Because I think a lot of what we've been talking about, at least what some
Also.
of the speakers have been talking about in terms of the difficulty, is in the management piece, but not on the question of whether or not it can be accurately identified.
I take your point and we'll continue to discuss it. I am up to Dr. Lewis, and if I have you out of order, I apologize. And please put your 10 card down if you're done or have given up.
Roger Lewis, and I believe this is probably directed, excuse me a second, towards Dr. Sycom. If I understood correctly, you had, or you and your colleagues had previously developed a questionnaire that helped you identify or create definitions for treatment-resistant depression. And I've heard concerns that may have reflected difficulty in a primary care setting identifying these patients in a way that is reliable, and I mean the term reliable in the statistical sense of different raters getting the same answer, not in terms of validity. So my question is whether there is direct head-to-head evidence, for example, inter-rater reliability studies of the application of these criteria to define treatment-resistant depression that compares primary care practitioners with psychiatrists or specialty psychiatrists.
As far as I know, the answer is no, that there hasn't been any comparison in primary care versus specialty care. But in reference also to your question, a simplified form of the ATHF, one that is much more suitable for primary care instances, was created by one of the companies, a TMS device company. And that has been successfully used, but with excellent validity data, but no reliability data.
You generally cannot have high validity without reliability. So if there was a success in validity, that would be implied. Can you define success?
Predicting outcome of the trial under double-blind randomized conditions, that the assessment of treatment resistance in the neuronetics trial was what got them, in fact, their FDA approval, because it was so fundamental in determining who got well with the treatment relative to sham versus where there was no effect. And so that helped validate their measure, which has now been used in other studies as well.
Thank you.
Okay. Dr. Gaines.
Yes, thanks. Just to, I guess, one point and then maybe one question. The one point would being, you mentioned the difficulty in primary care doctors successfully identifying depression in some of the studies, and I agree that that has historically been true, but my reading of the literature, and I think this is consistent with what the U.S. Preventive Services Task Force now says, which is that people should routinely screen for depression in primary care and other related settings, is that with that screening piece in there, there's now actually the assumption that the standard of care is that folks can be identified and at least begun on treatment. So I think that the accuracy piece in primary care has been noted to improve. The other point to make, again, just in discussion about what was said here in terms of the concerns about barriers to adequate treatment, that most of the studies that have looked at barriers to adequacy of treatment are really kind of nationally representative in terms of folks who are going in for an initial treatment for depression, how many are still on it a couple months down the line, 6 months down the line, et cetera, but not specifically for TRD populations, or at least those who failed 2 or more medication treatments. So that I think the best data on that still remains STAR-D, in which with an algorithm of measurement-based care, they were able to be faithful to the treatment in about 80% of the cases. So it's, and that was in primary care settings as well as in psychiatric settings. I guess what my question is, I'm interested in hearing from the any of the speakers, is in terms of that identification of TRD in primary care, not the management piece, but in terms of the identification of TRD in primary care, from our speakers, how effective or how accurate do they believe that primary care doctors can be?
Dr. Trivedi, Dr. Rudorfer, do you have an answer to that question? Is there empiric information on that?
Right. So that is why I was smiling at Dr. Gaines. We don't have data on this, so that is really a big issue. We don't have the data to prove one way or the other. My suspicion is that it is going to be hard.
Okay, thank you very much. Professor Melkus.
Yes, Gail Melkus. We heard this morning about the great diversity in the populations affected by treatment-resistant depression, and that goes in terms of age and gender, race and ethnicity. And I wondered if somebody could speak to the reliability and validity of the Hamilton Depression Rating Scale, particularly because it's one that's filled out by the healthcare provider, and for this population in particular versus somebody who has depression that is responsive. And then I was also taken by the fact that the medical outcomes studies SF-36 is used in this population, and how much you would expect that to change, especially in an older population.
There are excellent data on the reliability and validity of the Hamilton. CAPAs usually between observer ratings done independently are 0.95 and above. It's something that trained raters are excellent.
With this population with treatment resistant?
Yes, for instance, in ECT samples, which are highly loaded with treatment resistance. That's what we, in many, many studies, have found. And the correlation between the Hamilton and the BDI, for instance, is in treatment-resistant populations is just what you see in the general depression population, that the correlation improves with treatment. It's at the end of treatment 0.8 and above. So it has concurrent validity as well as reliability.
What about as this country continues to get more racially and ethnically diverse and older?
Well, in these samples, over 2/3 of the patients were elderly. They were above the age of 65. We can't address the racial diversity, whether the scales performed differently in them. Our group just published in the last couple of years several papers on functioning using the MOSF-36 in ECT samples. And these treatment-resistant patients come in with scores that are unbelievably low, far lower than comparable depressed patients with comparable Hamilton scores. Treatment resistance, and in particular referral to ECT, is associated with deficits in functioning. That's one of the reasons people are referred for that treatment. And after treatment, we could not distinguish the scores of this population from the normative data for the MOS-36, so massive improvement.
Thank you. Just how many categories does the Hamilton rating scale have? I'm just surprised to hear kappa exceeding 0.9 for anything.
It's not categorical. It's a continuous scale. The 24-item measure can go from 0 to 57, 58, something like that.
Okay. All right. Thank you very much. Dr. Saliv.
Marcel Saliv. I have a question for the first two speakers about could you please comment on the proposal from Dr. Conway and his group on this two-stage treatment-resistant depression definition that he proposed? I think this is relevant to question number one. So it appears to be based on the levels from the STAR-D trial, but it would be done, I think, for future retrospective assessment rather than enrolling people and making them go through those levels and failing. So can that be standardized, and what's your opinion on it as a standard definition? Would you recommend it?
So, at least my understanding, that was, I had not studied it before. My understanding is it still defines treatment, adequacy of treatment steps the same way, except that at the end of 2 treatment failures, it becomes quote unquote a stage 1 failure, and then later on a more extreme stage failure that introduces treatment options based on sort of current logic. And I should let them comment, but I don't think there have been enough studies that would then tell us that at the end of 2 treatment failures, you should use this treatment and that treatment, and not the others, right? Those kinds of studies, until they are done, I don't know how to recommend.
But could you think you could enroll people in such a study and say randomize them to
After having
different
had 2 treatment failures
Yeah.
based on adequate, absolutely. I think that these measurement tools are, while not tested with inter-rater reliability, I think they give you a good idea of the duration and the dose of the treatment exposure, and then they can be identified. And a lot of quote-unquote treatment-resistant, the field actually accepts the fact that there is treatment-resistant depression as an entity. This is not a question in my field. And in my field, when that question is raised for treatment options, neurobiology studies, we actually use these instruments in order to identify and recruit patients to come and participate, and they agree, and we have large-scale studies. So I think that is not, that identifying that group in research studies at least has been done. Clinically in psychiatrist practices, it can be done. I think Dr. Gaines asked about whether that then translates into primary care. That may be harder.
Thanks.
Can I just, to clarify, so the question I heard you ask, Marcel, is not, the answer didn't apply to the question I heard you ask. So let me try it again, but again, I might be wrong. I thought the question was whether the additional stratification gave us more insight into the clinical trial results. That this multi-stage category, as opposed to simply a binary distinction, was going to make either trials feasible or unfeasible. I think you answered that question, which was still feasible. But, or maybe it's my own question, so I'm going to take the prerogative of the chair to just ask it. Would it help? Would that further stratification of patient populations help us delineate the impacts of the new treatment, the treatment under investigation, as opposed to having the simple binary approach to categorization?
I think so, but you are going to have to then create a national consensus on this in order to then entice more people to do research studies to facilitate a new system. So it can be done. I'm just saying that means that's going to require more work.
Thank you. I think Dr. Carpenter was next.
Yeah, so this goes back a little ways, and it may be Will Carpenter, Maryland. It may be easier to ask the question of if you disagree with what I'm concluding from what I've heard. So, of course, the different disorders are heterogeneous, but the depression itself may not be so heterogeneous across disorders. And I don't think you're asserting that the treatment of depression is remarkably different depending on whether it's drawn from bipolar, psychosis, unipolar. It's more that there may be additional treatment things. So in that regard, the first question is there any reason to think that you could not identify treatment-resistant depression in these different disorders, with it being another question about if your clinical trial should be restricted to one or the other? And just to add to that, if we're considering clinical application, then to me it's unthinkable that in clinical application that one would attempt to apply the stringent criteria that you need to be sure in clinical trials. If somebody comes in that has had treatment failures in previous episodes, you're not going to tell them now we're going to spend the next 3 or 4 months proving that you qualify for treatment resistant. So also would like to invite a comment on how you would think about the criteria differently in clinical application than you would for clinical trial purposes.
So, Dr. Carpenter, for the first part of it, as you know, for bipolar depression, for example, the data are not there to support us the facility to go antidepressant after antidepressant to really call it treatment resistant, because the data are actually questioning whether you should even use an antidepressant medication to treat the depression by mood stabilizers, and you can go through the algorithm for mood stabilizer. So it is a much more different algorithm to use. And so yes, we should define bipolar depression as treatment resistant when it is, but they are not the same. That's why the segregation of the subtypes. Same thing with psychotic depression, also probably not enough literature to show what to do as a sequential treatment approach for psychotic depression, but there also you're likely to use different parameters to define that resistance. To your last point about, and I may have missed the middle one, but whether the exact research-driven approach is going to be applicable in clinical practice, and that's a very important point. We don't do that in most of medicine. In depression, in depression which is not defined as treatment resistant, randomized control trials that get FDA approval use Hamilton Depression Rating Scale as a measurement tool. In clinical practice, very rarely it is used. So that translation into clinical practice becomes a different parameter, and then people can talk about how to do it. Does that answer your question about that?
Yes, but give me your estimate. In clinical practice, I would assume clinicians would use past history of inadequate response, not just say twice in this episode. Is that type of change likely to make any remarkable change in the concepts that's being captured of treatment-resistant depression?
So I agree, yes, there will be slippage in terms of how stringently the criterion of duration, dose and duration is applied. And so that would affect the group that will get defined as treatment resistant, I assume.
You would assume less stringent is better?
No.
In clinical care?
I wouldn't think so. I wouldn't think that less stringent is better clinical care.
To be clear, what I'm imagining is people who have a life course of depression, are currently depressed, you know a lot about them, and you're saying you don't move them into this category until they meet very stringent criteria, while they then, if they don't get the treatments for it, are likely to be exposed to a substantial length of suffering because the stringent criteria are too stringent.
No, I understand the risk of wanting to have the stringent criteria, but it doesn't have to be prospective. It can be retrospective, so that is allowed. Nobody has to give them 2 more trials, but to be able to document how that adequacy was there, some degree of precision would be important, is my view.
Thank you.
Thank you. I have Dr. Ohlendorf and then Dr. Listig, and Professor Malkus, is you okay? And after that, I'm going to ask for last round for questions, and then so if you have more, put up your card. Go ahead, Dan.
Great, thanks, Dan Ohlendorf. So, Dr. Conway, in your presentation, and I know when you went through the responses to the voting questions, it was a little rushed because it was toward the end. But you do mention that there's consideration that an adequate trial of psychotherapy could be considered equivalent to an antidepressant trial. I'm wondering if you or any of your colleagues have done work to set parameters around that. Is that based on a minimum number of sessions? Is it based on core components or elements of the approach? Certain types of psychotherapy, as Dr. Rudorfer described, are not widely available across all parts of the U.S. And then a kind of an adjunct to that question, and it's sounding less and less operational as I think about it, but if this is something that could be considered as part of a TRD definition, for patients on combination therapy, drugs and psychotherapy, would both aspects of treatment be subject to the TRD definition?
Yeah, I think to answer the first question, I think the operationalizing therapy can be challenging. I think the STAR-D trial, and Dr. Trivedi knows more about this than I do, but the STAR-D trial was did have an arm that operationalized psychotherapy, cognitive behavioral therapy, and interpersonal therapy. So we would be in favor from a Medicare-based research perspective, using therapies that are empirically proven therapies. So those two in particular, I think, are the most established. Not that there aren't other therapies that work well. Then in terms of the availability and accessibility, I think this is one of the reasons why we said it could be looked upon as a treatment trial, but not a mandatory thing, because it's not available to everybody. The type of therapy that was done in the STAR-D trial, and I believe this is correct, Dr. Trivedi can correct me, but it was weekly psychotherapy by someone who was specifically trained in a particular empirically based therapy for 3 months. It might have been 2 months or 3 months, I'm not sure. But I think there are ways that are accepted in terms of doing standardized psychotherapy.
Thank you. Dr. Listig?
Ted Listig from Medtronic. And this is mostly actually answering the previous question. I just sort of want to solidify the thoughts. So I heard from you this question along the lines of, can CBT, IPT be considered as potential treatments to be considered in failed therapies? And Dr. Pope, earlier you had asked about the role of ECT. And I heard the answer there saying it shouldn't be a required step, but I believe it could be a permissible step. So what I'm looking for confirmation from our first two speakers is it the case that we can work with a may versus a must definition? So a must definition would say you must try different antidepressant therapies, and we actually had some discussion about whether they need to be separate classes or not. A may could say there are multiple therapies potentially available, including antidepressants, including the CBT, IPT, including ECT. And is it the case that it would be a reasonable definition to say failure of at least two of a class, of a set of treatments that could include antidepressants, ECT, psychotherapy? So what's your views on that possibility of saying whether or not it needs to be drug treatment, or whether it can be drug treatment or some of these other options as well?
A single drug treatment. Dr. Rudorfer, Dr. Trivedi?
So I think short answer is that would satisfy the general principle of treatment resistance. Specifically, if you want me to pin down to say yes or no, then it requires data we don't have. So you're asking the question that would require us to have sets of studies where people have been randomized to 3 steps inclusive of ECT and exclusive of ECT to say anything more than what I can say. So in principle, it does apply the same principle whether you try a medication, which has efficacy data, whether you try psychotherapy that has efficacy data, whether you try ECT that has efficacy data, and that would define having had adequate treatment trials, antidepressant treatment trials, and those who then do not respond will be treatment-resistant depression. Does that make sense? So it can include any permutation combination of a antidepressant treatment that has been shown to be efficacious. That includes medications, that includes these depression-focused psychotherapies, and includes ECT, although ECT has not been approved by the FDA, but it's been, the field accepts it as a treatment. Does that make sense? So that's sort of how I would think of it.
So I'm hearing you say that it would be acceptable to consider the inclusion of multiple therapy types in the definition of treatment-resistant depression. It's true that we don't have the same level of data for all things, but even STAR-D used a particular fixed sequence of treatments, and we're not necessarily saying it has to be that sequence of treatments anyway.
Right.
That's an industry. Okay. I have Dr. Lewis and then I have Dr. Yan. Is that right? Okay, go ahead, Dr. Lewis.
I have 3 questions.
Wait, okay, go ahead,
Oh, sorry,
please.
sorry.
No, it makes no, people are too polite. Dr. Lewis, that's who I called on, okay.
Roger Lewis, I'm going to try the Dr. Leistig strategy of telling you what I think I heard and then see if you agree. So I understand.
And then contradicting them if they don't agree.
Okay, so I'm doing the semi-Leistig. So I hear very clearly that the treatment strategies for patients whose depression is complicated by psychosis or is bipolar in nature is fundamentally different. What I didn't hear was whether an approach in which you count appropriate treatment trials for the disease the patient happens to have could be applied uniformly across those different etiologies or sorts of depression. So hypothetically, if one used a definition for unipolar depression which was based on 2 adequate trials of appropriate therapy, and assuming you define appropriate therapy correctly, would the similar type of definition applied to those with bipolar depression and those with depression with psychotic features, assuming again you had separate definitions of what was appropriate for those subclasses of patients, would that make sense and capture the concept of treatment resistance?
I would say at our standard level of knowledge, it could only be applied to unipolar depression, that we don't have. There is no bipolar equivalent of the STAR-D trial. There is no psychotic depression version of the STAR-D trial. So my thinking would be at this point in time, we would only be able to apply this to unipolar non-psychotic depression. But if further data were collected, I think a similar model could be created down the line. But right now, I don't think we have that data.
So I'm struck by the fact that right before you gave up, some of your neighbors were nodding yes before you came up and said no. So I'm wondering if any of your neighbors have an alternative point of view.
Just for the record, we prefer verbal responses. So do we have any head nodders ready to come up?
I would like us not to get overly weighed down by what we have clear evidence for and what we don't have clear evidence for. In terms of general clinical practice, yes, once somebody that I've seen who has psychotic depression has failed 2 reasonable courses of treatment, you would consider that that's a more difficult version of psychotic depression. That's a more difficult version of bipolar depression. I understand Dr. Conway's concern that we really haven't operationalized that definition from a research standpoint, but from a clinical standpoint, from my everyday caring for folks with difficult to treat mood disorders, that's what winds up happening. And I do think that it's all under the category of, let's call it treatment-resistant mood disorders. And what the most important thing is to be able to differentiate so that you know from the get-go whether you're dealing with a psychotic depression, a bipolar depression, or unipolar depression. But I think that those can all be under the general topic of basically treatment-resistant mood disorders.
Thank you.
Thank you, Dr. Aronson. Dr. Yan.
Evelyn Yan. I have 3 questions. The first 2 questions are related to the outcome measures. And for these depression scores, looks like most of these validity and reliability studies are from cross-sectional studies. Have you seen this study validation reliability from within patient reliability? Which means is for patient, they got a depression scale today, will that be very different 2 weeks later if other conditions are the same? That's my first question. Second question is...
Actually, let me ask you, you definitely get to ask all 3 questions. Let's get an answer to that question and then go on to the next one. Is that okay?
Yeah, sure.
Do you have someone you want to ask that specifically? Or is there somebody who feels like they have fluency with that important technical issue? The question is within patient consistency or reliability of the scales.
Generally speaking, particularly in the TRD population where you see much more chronicity, you don't see a lot of wild fluctuation in scores. That if you see a progression change over time, it's usually because of the beneficial effects of treatment. So yes, there's high reliability to these scores. And in fact, these scales are used intimately. For instance, in the practice of ECT, it's these scale scores that determine how many treatments the patient receives. You're going by the change in these scores over time to direct the nature of the treatment.
Thank you very much. Dr. Yan, your next question?
Second question is, a lot of clinical trial study statistical power are based on the primary outcomes. And looks like most study also using multiple outcomes, for example, depression scales and also remission rate. Have you seen this large discrepancy from the same studies? If there is, do you think is this due to the statistical power? Because if the study based on the primary outcomes, you see some efficacy. But if the study is underpowered for secondary outcome, you usually don't see the effect size in significant results. Have you seen this kind of discrepancy for primary outcomes and secondary outcomes?
Well, I think it's probably a reasonable criticism or sort of a description of the evolution of psychiatric research to say that up until about 10 years ago, there wasn't a whole lot of emphasis on measures of overall functioning. And one of the things that I probably didn't have time to get to in my 7-minute presentation was that we think that one measure included in treatments or in studies operationally defining depression, you should have outcome measures that include overall functioning. Now, one of the things we do know about overall functioning is that that tends to trail the response from a depression standpoint. So the Hamilton score, the MADRS score will drop, but the SF-36, maybe a month or two later, that's when you start to see massive improvement. So they're not equivalent in their time course, but generally speaking, that's the trend you see where the depression gets better and then the function either travels with it or slightly behind it. So
what about the remission rate? How do you measure remission rate?
the remission is typically defined by, for each of the scales, there's a set point. So for like the Hamilton 21, a score of 7 would be considered remission, or a MADRS, a score of 10 or below is considered remission. So minimal residual symptoms. Essentially, you've effected a cure when we use the term remission.
Thank you.
Did you have a third question? Or that was the third question?
No, I have another. Can I have another
Yes,
one more
absolutely.
question?
But can I comment on the second question? It strikes me, I also saw the multiple outcomes, but it strikes me that they are to some extent nested or overlapping outcomes. You know, there's sort of remission, there's response, there's relapse, and those are all conditional on one another. So I think although they're not perfectly mathematically intertwined, it strikes me as, personally, as not a huge problem of sort of multiple uncorrelated, that is caused by multiple uncorrelated outcomes.
And just to confirm, for example, in STARDY, if you just looked at that primary outcome, it was going to be the same result whether you looked at that primary outcome or also looked at those other secondary outcomes. So it was quite consistent.
Dr. Yan, you had a third question.
I have a third question, is that from the studies, clinical trials, and observational study review in the literature, and almost all these studies are based on the average treatment effect. And would be, to me, in my opinion, is that it would be ideal that we can be able to identify those patients who are more likely to be TRD before applying treatment. Do you see any barrier? Is because, say, if without the genetic factors or without other, will you think we'll be able to identify, pretty much identify, develop like a risk stratification before they develop a resistance to that? Because once they are exposed to medication, it will be harder to treatment. But can we to develop a risk prediction to identify those who are more likely to be TRD? Do you see any barrier, or do you think, how can we move maybe research to this related to the clinical trial study and the clinical research study in the future?
I think the short answer is there's a lot of research in the country really focusing on that question. Not only treatment resistance, because that is true for everything, including non-resistant depression. If you can identify risk stratification through biomarkers and behavioral markers, or subtypes as the NIMH is currently pursuing, are all attempts at trying to be able to do predictive modeling before you get to that point.
What are the current, is there any results, is pretty much in terms of like a prediction is how accurate? Have you?
The accuracy is not, there are very good signals, but accuracy is not
It's not
anywhere
great.
where you can clinically use it.
Thank you. Dr. Cuyjet? Oh, no, please, Dr. Rudorfer.
Matt Rudorfer, NIMH. I just want to add, it was interesting to me when I went back and looked at that British Medical Journal trial from 1965. They made the comment that they had looked for, and there they were using 3 active treatments and placebo. They were looking to see if there were any demographic or clinical predictors, even in retrospect, to predict response to any of those treatments, and they found none, which I thought was interesting. But I was at a meeting a couple of weeks ago discussing Alzheimer's disease, and I found myself suffering from biomarker envy, because to see PET scans of pathological amyloid deposits in people who are fairly preclinically ill was very striking. And again, that's certainly not ready for prime time or office use, but certainly just the issue of who should be in your trial because they have this condition, and who should not be because they have something similar but not the same. And of course, raising, as you do, the idea of preventive intervention would seem quite amazing. And again, we are certainly not there yet in mental health, but we're striving towards that.
Thank you. Dr. Cuyjet.
Yeah, this question is for Dr. Fox-Rolling and Dr. Conroy. It's been alluded to before. You look at the STAR-D patient cohort, it's clearly not representative of the population at risk, and we've already seen gender differences demonstrated. So I'm trying to frame this question number 3, where TRD should be treated. So I'd like some feedback on your opinion if it's a specialty psychiatric center with really good registry data, because trials take a long time and they're very expensive. What your opinions are on the use of registry data in a specialized center to look at differences in outcomes among the different populations with different interventions.
Yeah, I think my inclination, if I understand your question correctly, is that one of the things that we've observed with other studies involving treatment-resistant depression is that because it does require a very careful analysis of who. I mean, part of the reason why I brought up this whole model of 2 stages is because we wanted to point out as a group that there's a spectrum of resistance. There's the people who are really, really resistant. Those are the kind of people I treat that have failed 8+ medications. And then there's people with lesser resistance. And I think the different studies for the more severe end of the spectrum that involve implanting devices in people and electrical stimulation, I think those types of studies are probably better done at centers of excellence or centers who have expertise in dealing with the population. I think for perhaps less invasive type treatments, you could see potentially using centers that weren't so specifically oriented towards resistant depression. Does that sort of answer your question? Or?
I'm just trying to get at an answer to what your feelings are about having data that's not randomized, controlled, blinded, in the populations at risk. And the other piece that I didn't answer is what you alluded to with the relapse and remission rates, which are after a 12-month period are not what you'd like to see at the end of the day.
Sure. Yeah, my opinion would be that for most of the type of work that I think we'd like to see done in terms of pushing the barriers of knowledge in treatment-resistant depression, that would be best done at centers of excellence or centers of expertise. That would be my opinion.
Okay. Dr. Fox-Rolling, you've been quiet over there as the health research. So you can.
Dr. Fox-Rawlings from National Center for Health Research. I don't really have much to add. I think if registry studies were done very well and in a complicated issue like depression that may be very hard to do, they could still be useful in kind of understanding the natural changes that we see in treatment-resistant depression. But a lot of the really powerful research that we're going to get that's going to give us new treatments or define the treatments more clearly are probably going to have to be more prospective studies.
Okay. Great, thank you. Dr. Burke, do you have a question? Otherwise, I'd like to... Okay. Thank you very much for all of the thoughtful answers. We're going to move to a discussion amongst one another. This is a time where the panelists will probably bring more of their own knowledge to this discussion along with questions. I, in general, don't like to foreclose the possibility of people providing more input. So although it won't be the same back and forth, please don't hesitate to stand up if you have kind of something to contribute. The goal here is to get to the best answers we can. So I'll start with Dr. Burke.
Wow. So interesting. Over 12% of primary care patients have MDD in a year. 2/3 of older adults receive primary care treatment for MDD. 68% of antidepressant prescriptions are written by primary care physicians, yet here we are talking about specialty, secondary or tertiary care of these patients. So I'm going to take another perspective. I'm a primary care physician. I see depressed patients. I have my 15 minutes with them. Okay. So a couple things. Firstly, I want to comment on the pseudo-resistance idea, because from a primary care perspective, you know, the idea that somebody has a pseudo-resistance because they're not adherent or they take a lower dose of the drug, you're really talking about, you know, that they don't have a biological effect. So that's really from a biological perspective. But in my world, there are patients who fail therapies because they're not adherent. And they're a failure just as much as anybody else is, okay? I have patients who I can't give full doses of these drugs to because they're elderly, they're 80-year-old ladies, and they're just not going to tolerate it. So that's a true failure to me. That's a true resistance. Even if it's not to you, to me, that's a true resistance. It's not a pseudo-resistance, okay? So I want to make that clear in the very beginning. Secondly, I'm going to say that I'm looking for a measurement-based system that I can use as entry and exit scales and to allow for serial monitoring. I'm looking for a quick, simple, and easy to understand definition, okay? And I'm looking for something that can work in my primary care practice. So my definition, okay, of what you call treatment-resistant depression, I'm going to see most of your depression. You're going to see very little of the depression. I'm going to see most of it, okay? And I'm going to treat it, and hopefully much of the time I'm going to be successful, and it's my failure that you're going to see, right? So what we're calling treatment-resistant depression is really what I call medication-resistant depression, right? Because what's going to happen is that patient's going to come in. We've got a screening tool that says patients, you know, depressed. I might give them a PHQ-9 or a QIDS, and the reason I give them one of those is because they're free. So let me be clear. You charge me $1 per test, I'm not going to do it, okay? Because I'm doing this over time. So any test that's going to cost $1 per test, now these guys can afford $1 per test because they're specialists. They get the big bucks. Us primary care docs don't get the big bucks. So nobody's going to give me $1 per test to do these tests. So I'm going to use the QIDS, or I'm going to use a PHQ-9 because they're free, okay? And so what's going to happen is I get the screen, I go in, the patient comes in, I got 15 minutes, I say, look, here's my PHQ-9, would you just go through that? Then I'm going to have to figure out what to do with this patient, right? So I'm going to hit him with a medication. I'm going to say, okay, let me give you this SSRI. and you're going to come back, and I'm going to follow you up with my PHQ-9, and I'm going to see if I'm doing any good. If it doesn't do any good, I'm going to try a different class. And I'm going to say, look, you know, this didn't work after however many weeks. We're going to have to try something else. And then we have the problem. The problem comes in with my patient who I've tried 2 drugs on and didn't work, and the patient's still depressed. So what am I going to say? I'm going to say to these guys, I have a medication-resistant depression, because that's what it is. Okay? I didn't do ECT. I didn't do all this stuff, because this patient sees me year in and year out. Okay? And I'm going to do my bit. So then I'm going to refer my patient as a medication-resistant depression. That's what I'm going to do. So, so to meet my primary, so I need a simple definition. So I circulated in advance exactly this definition. And I'm going to read it to you now. It's only a few sentences. All right, so medication-resistant depression is depression does not respond to a sequence of 2 appropriate antidepressant medications. Now, I can handle that in 15 minutes, okay? I can deal with that. Or maybe even 30 minutes if I'm feeling very lucky and he or she's got plenty of comorbidities that I could get, you know, high reimbursement on. Now, I define depression based on a scale. So now, in what I said, I used the quids only because the star D used the quids. And you've got to have a threshold. So let's just say that quids score is greater than 5. Okay, because I've got to have a threshold that's consistent across all my patients, that I'm going to treat them if the score is greater than 5. Now, maybe it's 4 today and 6 in 6 months, and I treat them when they're 6, but not when they're 4. But I've got to have something. And then what does not respond mean? Well, it means that the patient didn't have a remission, okay, with the appropriate dose and duration. And appropriate means appropriate for my patient, not appropriate for you guys and you know, your biological response rate, okay? Because my patients aren't appropriate in your way. They're appropriate in my way, okay? And then remission means that whatever scale I used, okay, with quids, it's now less than 5. So that's my definition. It's depression that doesn't respond to a sequence of 2 appropriate antidepressant drugs where I have a scale going in, I measure on that scale, okay? If they go below over the period of time that I say, then they've remitted. If they don't, I try a second one. If that doesn't work, I call it medication-resistant depression. I don't call it treatment-resistant depression because I'm not in the every treatment business. I'm not in the ECT business. I'm not in the vagus nerve stimulation business, okay? And I'm not going to refer people. So patient comes in and says, I'm depressed. Am I going to give them ECT right off the bat? Am I going to say, hey, we'll send you off for ECT today? No, I'm not going to. I'm going to try an SSRI, okay? And if that doesn't work, I'm going to hit them with another one, an SNRI or something, okay? Then I'm going to refer them to somebody, because I'm not going to be referring the ECTs. I'm not going to be doing the vagus nerve stimulation. So my definition is medication-resistant depression, because from the boots on the ground standpoint, okay, that's a definition that all your primary care docs could use, makes sense to them, isn't ambiguous, like what is treatment-related depression? Is it all treatments? Is it a selection of treatments? Is it a group of treatments? Is it 1 treatment, 2 treatments? We don't know, okay? So my view on this whole thing is free instruments, use the instruments going in, have a simple definition, and if they fail my medication-resistant depression, then you guys get them and you can call them whatever you want.
Thank you for that. And so just because all right, so the purpose of this discussion is to, between us, to share, think ideas, exactly like Dr. Burke just did, to help us hone in on how to vote and our comments surrounding that voting. So I'm going to make an attempt here to bring your comments down to a question level. And remember, I clarified the question 3 is about the clinical applicability of research, if you will, research standard or research quality definition. Without interpreting what you said, I believe you are essentially addressing question 3, item 1. What is the clinical applicability? What's your confidence level about the definition that can be applied to Medicare beneficiaries of TRD in a primary care setting?
Well, yes.
And I'm not asking you to declare your view on that
No,
per se, but I'm just trying to categorize your
Well,
comments so we can think about it.
Yeah, I think that my comments are more general. I mean, I'm proposing that what is the standard definition of TRD? It shouldn't be TRD. It should be medication-resistant depression, should be the definition that we're talking about today, because I have no idea what treatment-resistant depression is. I mean, is it ECT and then meds? Is it meds and then vagal nerve? What is it? You see, it's too ambiguous for me, and in a medical context, I think it would be too ambiguous for Medicare.
Okay,
Because
so,
of the heterogeneity.
so first of all, we've gotten the worst possible criticism. We have to speak into our microphones, and we are not doing that. So, so please, all right, please speak in your microphone. All right, so let me.
I'll get closer.
Perfect. Oh, that's perfect. Can you just say everything you already said again? No.
Maybe you could re-say it for me.
Well, let me put a point on it, and please, other panelists, chip in. There are 2 alternatives to what you just said, right? Which I interpret to be that the usefulness of some of the definitions have been bandied about for TRD is limited in the primary care clinical setting. And so there are 2 alternatives. One is to sort of work upstream, if you will, to try and take a practical clinical definition that's applicable and apply it in the clinical research context. And the other is to sort of believe that there's a clinical kind of research quality definition, which, as you've described it in primary care, is difficult to translate. But either of those, in terms of thinking about the questions and how we're going to characterize our views on them, those are both possibilities. And so I think as we're talking about the research question of TRD, we should take that into account. But you can end up in either of those 2 spheres, if you will.
And I'm saying this is a 2-step process. I'm saying the first step is to recognize the primacy, no pun intended, of primary care. The first definition has to, because that's what's feeding you guys. And so the first step is literally, you're a conditional population, right? Okay? So in other words, these folks are all conditional. They're conditional on me having failed 2 medications.
Although, first of all, I want to go to Dr. Lewis's next, but to clarify, or to differ with you, the structure of the MEDCAC and the structure of the questions emanates from the research definitions of enrollment, and then, if you will, filtering out into the primary. So, but I want to go to Dr. Lewis, who's next.
Okay, but let me just finish. So the second point is the research definition. So once you clear the hurdle that primary care has failed, and the two medications have failed, then you move into the research domain, properly so, with the presenters we've had today. And so that then would be their then definition of these people that are coming to them, okay, from the primary care arena.
Thank you. No, thank you very much. Dr. Lewis.
Roger Lewis. So I have not heard anything that suggests to me that this is a useful dichotomy, breaking the research definition from the clinical definition, with apologies to the prior speaker.
That was him doing that. That wasn't me.
Please let Dr. Lewis speak.
In terms of a way forward in general, the degree with which the research definition matches a practical, feasible clinical definition in both primary and referral-based practices will help us generate evidence that can then be accurately applied in those settings, because we'll actually be able to identify the population to which those research findings apply. I think it's highly likely that no matter what we come up with, we will learn over time, as we understand mechanism better, that any definition that this group produces will in fact be identifying a highly heterogeneous population. We just don't know how to characterize that heterogeneity at this point. So again, borrowing shamelessly from Dr. Leistig, what I'd like to suggest is that there is a way forward that includes elements of the care that's available differentially in different settings to come up with a single applicable definition. So if one happens to be in a practice setting in which medications are the the primary or only mode of therapy, then there would be a way to satisfy the definition for treatment-resistant depression that depended only on medications. If, in fact, for whatever reason, one was in a setting in which other modalities that had been found to have similar treatment efficacy were used routinely, then that would also provide a path by which the patient might meet that definition. And my justification for that strategy was the amazing consistency with which failure in one drug or one drug class or one mode of therapy was correlated with, but not perfectly predictive of, failure of another arbitrarily chosen treatment. That's a remarkable thing that probably simply underscores the unmeasurable heterogeneity in the population. So I would like to suggest that that's a way forward. Details to be determined.
Dr. Carpenter.
We need the details. That's the key.
I'll take my stab at this. So treatment-resistant depression would be on a dimension of severity, not a category. I think it has to be recognized in clinical practice, and don't think we have reason to think it could not be. And it's going to get recognized in a setting that, as you do describe, where there's less expertise and less time for detailed assessment. So if we're talking at the level of clinical application, I think we're trying to derive what's workable from the research that's been done. And when we talk about clinical trials, then that's a different matter. So I think we need to know actually what is the evidence that all forms of treatment are equivalent.
Good afternoon. May I have your attention, please?
Uh-oh.
Please join executive sponsor Anita Pender, Director, Office of Equal Opportunity and Civil Rights, for the Take Our Daughters and Sons to Work Day program, beginning at 1 p.m. tomorrow in the auditorium. If you have a child participating in tomorrow's event, please be sure to check in at the registration desk between 10 a.m. and 11:30 a.m. in the pre-function area. Thank you.
Okay, that is in this room, and I asked them to make the announcement so that everyone is brief. We have to be out of here by 1 p.m. tomorrow.
Well, I'll not start from the beginning again then. So for the clinical care, it seems to me that clinicians will make a judgment about this, and they're not going to make a judgment based on the implementation of a form that's used in research with more detailed ascertainment. But it is important to know whether this is a medication or any treatment. So whether the different forms of psychotherapy and CPT are equally predictive of non-response to a medication, or is it the medication data? I'm going to presume for the moment that where the strength of the evidence is that if you fail on 2 trials of a medication, the next medication is not going to work out very well for you. And we don't know whether we can substitute other forms of treatment in that. And in clinical practice, if they're making the right referrals, they'll be in more than one form of therapy simultaneously anyhow. So it does seem to me that we have to say, will this translate into clinical care, apart from how you'd use it in the research? And in that regard, I would think that its essence is going to be the assessment of depression and the effect depression is having. And you mentioned several scales, but different clinicians may use different things to get to that.
Thank you, Dr. Carpenter. And so just to keep, I'm going to keep bringing everyone back to the questions and to look at them and so to contextualize this conversation. So if you look, and again, I'm not trying to suggest a particular way of voting in any sense, but in question 1 addresses whether or not it is the sense of the MEDCAC to that there is a standard definition, and I'll characterize that as whether you like it or not, if you will. Is there this standard? Because question 2, if there's particular votes in question 1 that are lean towards higher confidence, then there's a discussion or opportunity to sort of weigh in on the possible dimensions, singular or multiple dimensions of that definition. So just to be thinking about your future voting, those are questions I think we're very much circulating around right now. I'm going to go to Dr. Listig unless there's questions regarding what I just said. Please.
So for question 1 and 2, as you read it, it's in the context of clinical research studies.
Yes.
Not care.
1 and 2 are about clinical research. Research studies. Question 3 is about clinical applicability outside the research context. All is relevant to Medicare beneficiaries. Please, Dr. Trivedi.
I'll make a very quick point. I
Yes.
think Dr. Carpenter's point is how actually most primary care practices today operationalize this without having these definitions. They arrive at a point, at some point, where they say, I have done what I can with 2 or 3 treatments and say, now you go see a psychiatrist. So they're currently operationalizing it in some way anyways.
That's right. Yes.
Understood. Dr. Listig.
Thank you. Ted Listig from Medtronic. And it is Listig and not Leistig, please, Dr. Lewis.
Sorry.
That's okay. So I did like your points earlier about saying that we should be considering the types of treatments that are available. So STAR-D, for example, very explicitly included psychotherapy as some of the steps that were in the treatment. And I think it seems straightforward to accept that different persons are going to have different tolerances in terms of what they're going to look for as they progress down a treatment spectrum. You know, what sorts of steps do they want to take before escalating in some manner? And people will have different decisions in terms of personally what they will think of what they might escalate. I think it's also useful to think about this idea that while we can talk about a dichotomization as to whether or not one is in treatment-resistant depression, there is certainly additional information that is valuable about the extent of that resistance. You know, we have more information available if you have failed precisely 2 trials, say if it was in the same class, versus if you had someone that's failed 3 different classes plus ECT plus psychotherapy. So while we can talk about a binary switch in terms of starting out within TRD, perhaps it can be useful to keep open the concept of, is it helpful to collate and report additional information about the severity of the resistance that we're talking about? And that could have use in deciding further treatments or the extent to which we'd want to foster further evidence on that standpoint.
Dr. Gaines?
Yes, I think a couple of the earlier discussants actually addressed a couple of the points that I was wanting to make. I think the additional point, however, was just a reminder that most of what was discussed this morning came from relatively large-scale trials conducted both in psychiatric as well as primary care settings using tools that are easy to use. There's self-report. The self-report tools work just as well as the heavily trained HAM-D administered type tools. So these have been translated into primary care. They have been used to show how well they can monitor response to treatment. And they can. They don't. The ones that are used, as you'd mentioned, they don't cost anything. Whether it's the PHQ or the quids or whatever. So they have been translated. They do work in primary care. I think one of the things that we need to figure out some ways. I'm trying to figure out how the patient-centered medical home works into this some, because that might actually allow some of that counseling or psychotherapy piece to potentially be done before the primary care doc is deciding whether to prescribe that first medication. So I guess really the main point is that I think what we've been discussing as kind of a definition of TRD, as well as its ability to be translated into primary care, has really been done in most of these studies, and in fact is a lot of what folks are doing as they're following either U.S. Preventive Services Task Force guidelines or American College of Physicians guidelines.
Thank you. Dr. Sarate, you had your card up.
No, I was just, the previous speakers have already addressed what I had in concerns, but I just didn't want to limit it to antidepressant trials, 2 failed trials, because, if you happen to have a good psychologist who's working in the same group practice as you, that, you could just refer if you're, so it depends. But I would say that permitting any modality, either medication or psychotherapy, will count as an adequate trial. Sometimes I would have concerns on 2 psychotherapies back to back go into ketamine, for example. So, it all depends. Some patients may have not had exposure to medication, and then you've been exposed into something more severe. So it depends on a previous medication history. Have they been able to be exposed to psychotropic drugs? Do they tolerate well before you go to some more severe treatment with more side effect profile? We're assuming that some of these treatments in TRD are better tolerated. Many of them are not. And so I think you have to keep that in mind.
Thank you. Dr. Cuyjet. Oh, no.
Sorry.
Dr. Salev.
Marcel Salid, I wanted to just give my take on the questions, and I think, the context is key. It's for coverage with evidence development questions. And so question 1 is really inclusion criteria for pretty more straightforward than this way it's worded here, because I think the word that I stumble on is standard, because I didn't hear any ringing endorsement from any specialty societies today, or leading specialty groups or research organizations. I heard, mainly I think individuals giving this. And so I think in a study it can be defined in an operational way for a CED type research project. And then after you go through that, then 2 is the components of the definition, and I think we heard a lot of good discussion of that. 3 is where you would enroll people from. I don't think we have to, worry greatly about that. I think, it would be helpful to people developing such a trial to enroll people from primary care clinics, I think, just so that it does become more generalizable rather than but of course I recognize how the research enterprise exists today, so it's just, more of a pragmatic issue. And I think that 3rd question is not super, important to this deliberation, but that's just me. I think 4 is on the outcome measurements for such a study, and, and I would agree with my colleague next door that specifying the primary outcome is key and having an analysis plan is key. And then the design is question 5. So it's, to me, this all hangs together very nicely, and I think we've had a good discussion.
Thank you. Professor Malkus.
Thank you very much for looking at it that way conceptually, because that cleared things up for me with number 3, because as stated, it would really be where you would get the patients from. And when we think about primary care settings, I'm a primary care provider, I always think of how we're going to evaluate these people just in terms of health literacy, language, and it's rural areas too. I mean, I'm from the tri-state area, and it's really problematic. I mean, the majority of patients we see, English is not their first language, so I think that's something that we need to consider. And I also echo the sentiment that we do have clinical licensed psychologists who could do the CBT and do other psychotherapy, and so maybe we could factor that in. And the other point that I want to make is, unless, I think there's an assumption here being made that psychiatrists there's plentiful, and they're not. So I want to know how we refer people so readily from primary care settings to psychiatrists. You're laughing because you can't find them.
Please.
Just one, this may make your task more complicated, but both psychotherapy and STAR-D have been mentioned many times, so I should clarify. In STAR-D, actually, we were very clear the psychotherapy option that was available at 2nd step meant that before you go to the 3rd step, there was an additional medication step introduced for those who did not do well on psychotherapy before they got to our formal 3rd step. So therefore, at least in STAR-D, we did not automatically substitute a 2nd step psychotherapy to define treatment resistance, just to give you a clarification.
Dr. Burke.
All very good points. Thank you very much. So what I'm hearing, so I also have not heard of a standard definition. And also I think the reason is because treatment-resistant depression, the treatments are so heterogeneous and can give it in so many different orders and so many different ways and so many different times, I think it's going to be very difficult to come up with an actual concrete definition of treatment-resistant depression. So my thought is that it's the failure, basically, in a sense, it's a failure of the primary care physician to achieve a remission that is what you might call treatment-resistant depression. In other words, if the primary care physician fails with, say, cognitive and/or medication resistance, so they have cognitive and/or medication-resistant depression, if they fail with two, okay, either two medications or cognitive and a medication, then that by definition is treatment-resistant depression. And that then sets you onto the second step, okay, of research, is that this is your patient population. This is your research population, those people who have failed that first step.
Dr. Ollendorf?
So I had a specific question, but first I want to respond to the conversation that has just been had. I'm still thinking about question 3 in terms of its application to clinical practice, not in terms of study enrollment, or at least not in terms of study enrollment alone. When I see the term...
I believe that's how you should think about it.
Okay. So that answers my question there. I have a specific question that maybe some of the guest panelists or other clinical experts can address, and that's on question 2, whether we should be thinking about suicidal ideation and suicide attempts as a single construct. Because I know we saw data suggesting that patients with TRD have a higher rate of suicide attempts, but, and this is a non-clinician's view, so tell me if I'm wrong, but suicidal ideation can be driven at times by disease and at times by therapeutic choices that are made. So should we be thinking about this as one item in terms of either a defining characteristic or an outcome, or more than one?
This is Brad Gaines. Can I address that? So a very important question, and just to recall that at least if you look in the large-scale clinical trials of those folks who are identified as having depression, this is true in primary care and OB settings and in HIV settings, somewhere between 40 and 50% will endorse suicidal ideation to some degree, say question 9 of the PHQ-9, for example. Maybe 75% of that is probably passive SI, but I think you're making a good point that kind of globally considering suicidal ideation together with suicide attempts is not a good marriage, because that's not going to really be able to distinguish TRD from what's commonly presented with most depressive illnesses.
And also suicide attempts ever? How long ago? How recent?
Yeah, those can be difficult histories to collect, for sure.
So I don't see anyone else waiting, so I'd like to ask you each to take a moment to look at the questions in anticipation of us discussing them more, maybe asking further questions, clarifying between one another, so that we can then, once we're through that, we can move on to voting.
I did have one question about number 2. The second characteristic, the use of, the first one, number, duration, dosage, and or classes of antidepressants attempted. I was trying to decide whether, is that meant to reflect something I think we've been discussing a lot here, which is the number of failed antidepressant attempts at some point. Does that capture that or not? Because it seemed, I wasn't convinced it was.
I'm actually not, my instinct is the answer is yes, but I'm not sure I want to be sure I understand what your question is.
So I guess what I'm thinking is when I'm thinking of a treatment-resistant depression operational definition, I'm thinking of 2 failed prior trials of some kind of adequate duration and dose. But I can't tell if that is what the number, duration, dosage, and or classes of antidepressants attempted means, because it's not clear to me that we've identified that they've failed to remit or that they've failed to be of an adequate dose or duration.
All right, let me take a stab. I think I understand your question now. Let me take a stab at it, and I'm going to propose something, agree, disagree. The way I read that is a somewhat general statement about the use of multiple agents in the on the way to defining TRD, but not as a granular definition of each dimension that we have to independently answer for now. I think, at least what I've heard most of the morning, is that there's a great deal of nuance in that first bullet, but at some level, I think it's just sort of acknowledging that bullet matters, and is sort of, the term is are important defining characteristics, and so it's an acknowledgement that that is or is not an important defining characteristic. But go ahead.
Yes, this is Dr. Miller. Yes, and that would be the correct interpretation, that this is how we would begin to define adequacy of a trial of medication, yes.
Thank you. Dr. Pope.
Just a couple quick clarifying questions. Somebody pointed this out. So question one is, how confident are you that there is a standard definition? Somebody already emphasized the word standard, and I'm wondering, is there a distinction between, is there a standard, it already exists, or whether one could be constructed or synthesized from the available studies? And just to clarify, what is the exact question that we're answering?
Well, all right, so I think the question as written is, the definition of the word is in this context is not in dispute, so it is currently, and as I characterized it, whether you like the definition or not, given the body of research we've heard discussed, whether or not you feel that that it's mostly converged on a standardized definition or not. For the purposes of this discussion, I think it has also become clear that further refinement, interaction, and development of such a definition would be useful, but I think that's all, at some level, that's always true. But I think you do have to sort of say, which way is the wind blowing? And again, I'm not trying to bias your responses in any way. In order to get to question 2, just recall that you need to sort of be convinced that there is a definition at some level, or we skip it, which is fine too.
So,
wait, Dr. Lewis, and then you, Dr. Burke.
So the clarification in subparts of question 5, the first 3 options clarify whether the study designs would include blinding. D, E, and F do not. Should we assume that those study designs would be blinded or unblinded?
We should just make a decision about what is meant here. Well, I believe that those are all unblinded. I'm not sure I know the difference between C and D.
Crossover would have to be unblinded in order for them to cross over.
Oh, no, it doesn't have to be. You can blind a crossover trial.
So any of these study designs could be blinded or unblinded, and they have different vulnerabilities to validity based on that. So I think the chair might just make a decision.
Oh, great.
I would suggest the chair define them as unblinded.
So we are talking about C, D, E, and F as unblinded to, and just in fairness, this is unblinded to the patient, to the beneficiary.
Correct. D, E, and F.
Yes.
And C. Yeah.
This is Dr. Miller again. They are unblinded.
Okay.
To the beneficiary.
Well, at this, they would be unblinded either to the beneficiary or to the investigator.
Yeah, it'd have to be to the investigator. They have to be unblinded. There's no way around it.
Clarification,
please.
Regarding number 2, ECT, electroconvulsive therapy. So did we agree it was could it be a must or may?
I'm sorry, where are you?
It would be number 2, the use of non-pharmacological treatments such as electroconvulsive therapy, transcranial magnetic stimulation, for example.
All right, the question is, so these are yes/no questions. This is where we get to do the thing with the cards. The language here is as to whether the following are important defining characteristics. So in that context, if you feel that non-pharmacologic treatments, if you will, failure of one of the non-pharmacological treatments is an important element of the definition of TRD, you vote yes. If you
So
feel
it's a must, or may?
May.
May.
It's a must.
A must?
A must?
Yeah, in the way it's phrased, on that bullet, we're going to vote on each bullet separately.
Okay.
In that bullet, they're saying, must is an extremely strong word, but that's what is intended. Is it a requirement or important characteristic of TRD that the definition of TRD that somebody has failed a non-pharmacologic treatment? And
You would,
yes
you
or
would
no?
basically exclude all psychotherapies and medications. I mean,
Pardon?
You've got to clarify whether you mean
Well-
to say important or required, not and. but which.
Well, it's
because if you require failure for electroconvulsive therapy, right,
Do
what
you
happens
feel-
to psychotherapy and what happens to medication?
Do you feel, right, the question to you would be, do you feel it is an important element of the definition of TRD that someone has failed a non-pharmacologic treatment? Put a different way, you either think that TRD can be comfortably defined without, for somebody failing, for example, just medication, or you feel it is important that they also fail a non-pharmacologic intervention like ECT. And yes or no? That's the question as I understand it.
So that's not exactly a dichotomy. You've sort of split the space up into three things and called two of them there. So I think another way
Help
to,
me.
Yep, another way to phrase this is to say, if you think it's important, then some consideration must be given to that. Consideration could be, depending upon your point of view, that must be an element to the definition or that may be a definition. Those both of those choices could fall under, I think it's important. The important doesn't necessarily require that it is a necessary step in the definition.
I understand what you are saying. My read of this question is it heavily leans towards must. It might not really be must 100%, but it is a different way of saying it is if you saw a trial where the enrollment criteria where people called TRD and they had not failed, or it was not a requirement, or it was not highly prevalent that they had failed a non-pharmacologic intervention, you'd be like, I don't think that's TRD. So that's my read of the bullet. I have no view of whether or not it is or is not important. I'm just trying to read the question.
If they've never had that treatment, if they've never had that treatment, how do you make your judgment as to whether you consider it important?
This is a definitional question, whether or not patients end up in the TRD bucket without having a trial of a non-pharmacologic treatment. Do you care? Is another way of saying that. And you can say, no, I'm comfortable. They've failed a couple of drugs. I'm comfortable they have TRD. Or you can say, absolutely not. They have to fail a non-pharmacologic intervention for me to consider them TRD. And to Dr. Lustig's point, it is unfair to be so binary, but I'm trying to help everyone at least locate the intent of the question.
Just to clarify in terms of how to answer, is we can say our vote and then just say yes under the circumstance. Can we qualify it? Or
All right. That's a process question. What we are going to do is we will vote. You'll hold up the cards, or it'll go up on the screen depending on if it's numerical or not. Then I will poll each of you, at which point you state your vote, your name, and then you can proceed to clarify. I'd rather you don't entirely disavow your vote, although maybe on the second voting you can, but that's the idea.
Yeah, I mean, that helps them. Perhaps.
I hope so. Dr. Cuyjet, and then Marcel.
I just have a question for consistency. In question 2, item G, suicidal ideation, suicide attempts are combined as a single category. And in question 4, they are separated. So for sakes of consistency, I'd appreciate some expert opinion as whether we should either leave them separate, as this question's already been raised, or combine them for both questions.
I agree. Does somebody can we get some view on, I'm happy to break those into 2 separate questions, ideation and.
Yeah, I would agree with you. I think it would be okay to break it into separate questions. I think suicidal ideation is more common in treatment-resistant depression, for sure. But the majority of people with treatment-resistant depression do not have suicidal ideation. So it is not an intrinsic characteristic of treatment-resistant depression. That's
Okay. Process-wise, I'm going to ask you about ideation first. I'll ask you about attempt second. So those are now
Should
two
it be
separate.
under suicidal
Right above
attempts?
right above other, I've added another bullet, which is suicide attempts. The bullet before is suicidal ideation alone.
So my question, Saliv,
Dr. Saliv.
is on the same number, the one bullet above that. So I think everything else is a little bit dichotomous, but the score changes on a scale. So if you're saying it's a defining characteristic of resistant treatment that your score changed, so, you know, there's such a thing as the meaningful, clinically important difference, and, you know, because it seems like if they got better, it's not resistant. If they didn't get better, but it changed, is that what this is asking?
Yeah, thank you for picking that up.
Can I offer a perspective, maybe?
Yes, please.
So the way I understood, I appreciate that point. This is Brad Gaines. The way I understood that is that when I was thinking of score changes, I was thinking of score changes, for example, to whether or not it met a remission threshold or not. After you explained to me what A was in terms of the number, duration, doses, and classes of antidepressants could indicate, you know, number of failed depression trials. Given that interpretation, it seemed to me that score changes could be consistent with an important score change, whether it's a clinically meaningful difference or it meets a definition of remission by hitting some certain threshold. That seemed to me to be meaningful in that way.
I'm comfortable with that as well. A different way of saying that is that you can view these bullets as domains more so than that the terms are directional. I appreciate that. And again, this is on me because I had a chance at these questions earlier. It could have been phrased more tightly. But the general question, I think, is that what I would like you to answer is, do you think scores measured over time are going to be an important component of a TRD definition? Is that fair?
Great.
Okay. Other questions? Dr. Pope, you had another?
Yeah, without changing...
Oh, actually, I think Dr. Listig's next, and then Dr. Pope.
Yeah, so I just wanted to come back briefly to number 5, which we've talked about very, very little here. And we're talking in there how confident we are that the following strategies represent meaningful and realistic study designs and research investigations. We have this list here. And I think it's, sure, there can certainly be a hierarchy that when all things are equally possible, one might have a preference for going through this. But it seems to be set up a little bit in terms of again, this binary thing about can such a study provide meaningful and realistic evidence or not. And in that context, I'd just like to point out, I mean, I come from more of a device setting. That's where my company is. And for example, in our FDA regulations, there is a language that states that the evidence for the FDA approval shall consist primarily of well-controlled investigations. But there's also language about other mechanisms that can be acceptable for providing evidence. And even in the language around evidence development, there's this discussion about how you could use registries, and that if you are in a registry, you need to register with the registry of registries. And so I just want to keep persons to be careful about thinking the difference between what your ideal study would be and whether or not some of these alternative designs could provide meaningful and realistic information. In some cases as an adjunct, and we're not necessarily saying it's the sole source of information. This goes back to Al's point a bit earlier about involving registries. Could there be a mechanism by which data from registries incorporated in such a manner could inform our knowledge about the treatment? And so I would encourage the other panelists to keep that in mind and not simply view this in terms of what is the best option, but rather whether these could be viable options for learning more about therapies.
I appreciate the comment, and I believe you're also saying something that is very true to how the question is phrased. It's realistic, it's meaningful, are the two critical terms in there. So absolutely, there's a pure form of research that can't always be achieved. I have Dr. Pope and then Dr. Burke.
Just
And then you're right?
on the earlier discussion about question 2, and this is maybe to capture the most robust information advice possible, and this would not require a change at all to the wording of the question, but every other question has, 1 to 5 weight scale, whether or not that would be applied to the subparts of 2 as well. In other words, when you ask how, in other words, the question wouldn't be, is it important binary, yes, no. The question would be answered, how important it is. And I don't know if that would get to Dr. Leist's, concern that, is it may, is it must. I'm just suggesting that as a way maybe to get more value information captured.
I appreciate that, and what I'll ask you to do, given how we've structured it, is that when you give your response, I would invite that's a great opportunity to add more characterization of it. I said yes, and I really mean it. I say yes, but I'm on the, whatever, or you can apply the same 1 to 5 scale, whatever you prefer, and you're not required to do that, but Dr. Burke, and then Dr. Carpenter.
So, does the chair have a standard definition? Does the chair have a standard definition of TRD?
No.
Okay. So the is, you say means what? Because you said is means is.
All right, so we're looking at question 1.
That is correct.
And it is phrased to each of you, not to me. How confident are you, Dr. Burke, that there is a standard definition of TRD that can be applied to Medicare beneficiaries?
Okay, so taking this in its totality, would a standard definition be 2 consecutive effective antidepressant failures? Would that be pretty much what we've heard today? That it would be 2 consecutive, but it has to be effective antidepressant failure. All right, so two things that are effective in treating depression, they're consecutive and both failed.
All right, let me propose this. The way we have phrased it does not, weirdly, maybe, or I actually think helpfully, everyone can say yes to question 1, and everyone can still disagree on what that definition is. That seems a highly unlikely event.
Wow.
But the first question is simply, is there a starting point in the current state of being? All right, with current research, is the verb. So what I would invite, again, when you cast your vote, I think that's a perfect time to then articulate that, if you vote, let's say I'm not leading you to a particular vote, but if you say yes, absolutely, give it a 5, then when I poll you, I'll ask you to then say, and again, you don't have to, but if you would like to, you can say, and my definition is X. And it's not what you wish it to be. No. That's the topic in question 2, right, to some extent. It is, what do you believe the current state of affairs is in the research community with the definition of TRD? Fair?
Fair enough.
Okay. Dr. Carpenter.
Okay, just get me unstuck on 2 things. On number 4, why is it decrease in suicide ideation rather than decrease or increase? The ones above that allow for getting better or getting worse.
I don't have any problem with the directionality of those. Those are undesirable, right?
No, improvement in function is desirable, decline is undesirable. It just doesn't parallel.
Okay, we will, all right.
And that would also reasonably reflect, some concerns, might there be some increase in suicide ideation
I see.
for particular age ranges?
I apologize, okay. It's simply, I will ask you to interpret all 5, A through E, as an alteration of clinical, that has a meaningful clinical difference. Without directionality. The implication is, of course, that there's a desired directionality.
Yeah.
Fair?
Yeah. So the other one,
Please.
You've got to get me unstuck on. So we're scoring over time on number 2. Is that what you said? What is this?
I'm sorry, your question?
No, I'm back to number 2.
I'm on 2, yeah.
And I believe you said that these were things to be scored. So I'm stuck. Is this relating to what needs to be in the identification of a category of TRD, or is it meant to be tracking progress of a patient?
No,
who's been identified?
the former. You could think of them as entry criteria for a clinical research study.
So the scoring over time didn't apply to this,
Um,
as you said earlier.
Again, so this is my interpretation. It would be the scores over time that define, like these other, all of these definitions are intrinsically sort of to the left of entry, right? They are
Okay.
longitudinal in
But
nature.
it's not a change score.
Well, it could be a change score, it could be something about these scores, right? But they are, if you will, to the left in time of entry. So, failures of multiple therapies, consistency of scores, so be it, right? But these are all things that you would choose to have within your definition of TRD, that when somebody has X, Y, and Z, they have that, at that point, you can then say they have TRD.
The minimum definition of TRD.
Well,
That's
but
what we're
it's
saying.
not. It's not
Because,
actually. No.
what is the
No.
gate to get into a study?
It is what you think are important defining
Because
characteristics.
all of these are very important in TRD, and some patients can have all of them, but they would be at the higher end of the spectrum. So to get into a TRD trial, at the minimum, you
Right.
would need 2 antidepressant failures or psychotherapy or something.
Absolutely. No one is saying any of these features, domains, or experiences of patients are unimportant. This is a clinical research question about what the entry criteria would be, if you will. Dr. Gaines, and then Dr. Pope?
Just a question on number 5.
Dr. Gaines?
Yes, just wondering exactly where this would fit in. So for number 5, when we're wondering about meaningful study design, so where would large-scale pragmatic clinical trials fall under? Would that fall under either A or B, depending on whether they're single or double-blinded, or is that its own thing? And I'm thinking about large-scale, databases, clinical data research networks covering, hundreds of thousands of folks, and you're doing trials on them. So they're large-scale pragmatic trials.
All right, so if I can rephrase what you're saying, you're asking about large-scale observational research with no experimental design?
No, there is an experiment. You'd randomize folks in some settings to one treatment and some in another treatment, but you're monitoring them through electronic health records, so you're able to follow thousands and thousands of people.
Okay, fair enough. Is it blinded?
Could be single or double-blinded. So I guess my question is, would that fit under either A or B, depending on whether they were single or double-blinded? So just the large-scale clinical trial design.
No, fair enough. I would ask you to narrate your answer with respect to that, because I think, as you've just said, and my understanding as well, is that the scaling issue, the pragmatism, the allocation methods, although they differ, probably all fall under traditional research study designs.
Okay.
I'm doing the best I can here.
Can I just briefly clarify?
Dr.
that?
Listig.
Yeah. So Ted Listig from Medtronic. So I would say when you're talking about those large-scale pragmatic trials, you're not talking so much about either the assignment of treatment nor of your knowledge of the treatments assigned. You're talking more about the recruitment of the patients and the monitoring of them over time. As such, those two elements actually don't speak to the design we're talking here. So to underscore the fact about, talk specifically about the elements here, that type of trial setup doesn't put you into one of these buckets.
Thank you. Dr. Yan.
He answered the question.
Is that everybody?
Yeah, I just want to clarify, but he answered.
Oh, yes. It's the other way around. Great. We are going to vote. I recommend we take a 5-minute, not 5 minute and 1 second break. We split ideation and attempts into 2 minutes.
So that would be question.
I promise that suicidal ideation is 1 vote.
Yes. Okay, got it. Yes, we'll take care. John? Yes. You need to. You have to. So you're the industry. You are the industry rep.
Their votes? No.
We still vote. We will count. We're going to choose that. So it will be counted. I'm looking for John. I think it's very important.
Especially
If you don't talk to me, you may be I gotta go find John.
Yes, and so no, and I
From
wasn't.
Columbia University.
No, I know that, but it doesn't. It's not.
I got up.
That's why I did that I was trying to work around.
We're trying to get it moving.
Hi, yes, please.
We need to hurry up before they start. So do I have to do it here and then send it to you?
I do it here. I can do it
I did not, you know what, I was in every opportunity.
Okay.
Yes, I know. Well, I also I was like, okay.
Now I'm going to say something.
Dad, no, that's good. I hope Dad counts.
Yes, you must have like shortened it because you guys worked from the video.
Okay, so again, we gotta get in can. We know this. That's right. And can you get your girl on the shirt? That wasn't my business. That was your girl. That was your girl on the shirt. Oh, I can't do my mouth. Ma'am? Okay. Yes, it is. That's fine. Thank you, John. Yeah. It is my fault because I'm the one who's going by candy. No, you're not. Stop trying to get you candy. No, I will buy the. Thank you, John. Now I just got to figure out them with their score sheets. So you're going to kill me, but for some reason it did the exact same thing. So which one? Number 4. Mm-hmm. And 5.
I don't know enough about the scale.
How do you go split?
We had a joke about we said they had a name for everything that was because when I trained, man, I tell you, you're challenged to just walk in the room and Eric walk out, we'll test you and say, round squats. Round squats.
Only because the sheet that I created. So, for this, because I created the free score sheet, so I'm going to ask the panel members to, since I did extra space, because you have, right, because we broke it down, right, because we split, I'm sorry, because we split people. We can do.
This is an interesting exercise.
Oh, God.
Unless they want to chance it in tournament. So.
I think I'm going to blame Peter for this exercise of futility.
Okay.
Jesus Christ, you're killing me here. You know that, right?
How do you think I feel?
So since we're splitting this, and because all the panel members, they have a sheet score sheet. So since this is being split, I think I need to get all the way down to maybe right.
I'm gonna
Put
come up
that-
with a
Yeah, put it
system.
in the other category.
Because are we going to vote on other or
No, the other is pointless.
So we're not going to vote on
We
other.
have
So for suicidal attempts, just ask them to draw a line to other and cast their vote.
Can I write on your?
So this is his, because he's going to have to write on it. He's going to need to report his vote, and I have to
Okay,
take this.
I'm gonna tell them right now.
Right, and if not, I.
Can we sit down and get going, please?
So he wants to see you, so just ask him for suicidal attempt to put it under other. Right.
Yes, please. Then we're gonna rock and roll. Yep, I think we're on time. Hi, can you take panel members? You have a pink sheet in your packet, which is your hand scoring sheet. We're also going to electronically score. Sorry? Oh, some have yellow. Pink or yellow. Under question 2, this relates to the very last bullet. We're splitting suicidal ideation and suicide attempts. So I'm going to ask you to cross out the word other, which we are not going to vote on. Cross out suicide attempts in the line above, and then write suicide attempts where the word other was.
There we go. And I shall do that.
Thank you. So we're going to commence with the voting. Does everyone have their thing, their electronic? Okay. All right.
Oh, so this one down here, that's right. Yeah, that goes right there. This one.
All right, beginning with question number 1, and again, if there are questions of clarification or concern, this is a process that is intended to achieve useful information. Please stop me or ask questions. And just to make sure, Dr. Gaines, Dr. Carpenter, you don't have questions right now. Your cards are still up? Your 10 cards are still up? Okay, great, okay. All right, question 1. So you're supposed to use your gizmo here, and I understand the people at the end of the table don't have one? We don't have it. In which case, we'll ask you to vote verbally, and also, of course, record it on your sheet. How confident are you that there is a standard definition of TRD that can be applied to Medicare beneficiaries in clinical research studies of therapies for this disease? And so we can sing the Jeopardy song.
Mm-hmm. Almost. Waiting on 2 people. 1.
Thinking government.
We're just waiting on 1 person to register their vote. If you can you please just push your last vote again?
Just push really hard on the number.
Thank you.
All right. The score on that is 3.8. I'm now going to poll the panel for your individual responses. And if you recall, based on our discussion, you have the option to say anything you want, but something that people were asking for was you can, for example, state what you believe the standard definition is. I ask you to be concise. I'm going to start with Dr. Cuyjet.
I voted for.
Dr. Burke.
I voted 5 because I believe that the standard definition is failure to achieve at least 2 consecutive effective anti-depression remission. So failure to achieve remission using at least 2 consecutive effective antidepressant therapies. That's what I heard.
Thank you. Dr. Cruz Flores.
I voted 2 because I think we need to include the alternative of other therapies like ECT or psychotherapy.
Okay, thank you very much. Dr. Lewis.
I voted for and agree with the prior speaker's comment.
Dr. Melkis.
I voted for as well.
Dr. Ollendorf.
I voted 3 for the same reasons that have been listed earlier.
Dr. Pope.
I voted for.
Dr. Saliv.
I voted 3.
Dr. Yan.
I voted 5.
Okay, and then you 4 didn't vote electronically, right? So this could be a complete outlier. Okay, Dr. Listig.
So I voted 3. I think that the definitions exist. I'm interpreting this more in terms of could it be applied well, and I think that there's challenges with the current existing definitions. We've been talking about modifications.
Dr. Carpenter. And please speak into the microphone. I was asked to not address me, but address the audience if it's easier to remember to speak into the microphone.
So I voted a 5. I think the construct is simple and straightforward. I think it's incredibly important that it be used in clinical practice. I think the research shows that there are reliable and valid ways to do it that have enough ingredients that can be translated into clinical practice.
Thank you. Dr. Gaines?
Yes, I voted a 5 based on both clinical trial research experience as well as reviews of how accurate these tools can be in primary care settings.
Thank you. Dr. Sarte?
I voted for 4. I think there's room for improvement, including a little bit more clarification of some of the definitions, duration, adequacy trial, psychotherapy as well.
Thank you. We're going to move on to question 2. And may I ask if the 4 of you at the end, do you have cards? Yes. Okay, great. I don't think we've ever done this before, have we? So this is going to be fun. This may be something you want to Instagram or something. Yes, please also mark your vote on your sheet, and I ask you to do it now so we don't end up with a reconciliation problem down the road for question 1. Number 2, I'll read each. I'm sorry.
2 cards are missing for Dr. Carpenter.
Dr. Carpenter doesn't have a. Okay, we'll ask you to do thumbs up or thumbs down, I guess, if we don't have. Do we have more cards? We're going to make. We do it all here.
I'll write it here.
I think we're violating the Paperwork Reduction Act right now, but.
We can't see that. Yeah, it needs to be colored. You could use somebody else's.
And then how was it answered? Right now? Okay. Yes, I figured. Okay, I'm going to begin reading the question. If intermediate confidence is noted above, please vote yes or no as to whether the following are important defining characteristics of TRD that are to be considered in clinical research. Bullet 1, yes or no, the number, duration, dosage, and or classes of antidepressants attempted. Please raise your cards.
Man.
Did we get that?
Yes, we just need everybody to see it.
Okay, please indicate your vote on the sheet. Okay, all right. Next bullet, the use of augmentation combination.
Did you want us to comment any?
All right, so what I'm going to do, if this is okay with you, is I want to do them all and then ask for comments. Otherwise, I think we'll be hopelessly caught up. Again, if you feel like that's not a good process, okay.
We need them to say their vote in the microphone so it's recorded on the minutes.
I apologize. Could you vote again on bullet 1, and then Dr. Cuyjet?
Yes.
Dr. Burke?
No.
Yes. Roger Lewis, yes.
No, I'm sorry, yeah. Dr. Malkus?
Yes.
Dr. Ollendorf?
Yes.
Dr. Pope?
Yes.
Dr. Saliv?
Yes.
Dr. Jan?
Yes.
Dr. Listig?
Yes.
Dr. Carpenter?
Yes.
Dr. Gaines?
Yes.
Dr. Sarte?
Yes.
Great. It's like sense of the Senate. Next bullet, the use of augmentation combination / combination pharmacologic therapies. Please vote. And while you're holding your cards, I'll just go down. Dr. Cuyjet?
Yes.
Dr. Cruz Flores?
Yes.
Dr. Lewis?
No, because I was interpreting this as a
I'm sorry, Dr.
You don't like my no.
Dr. Burke?
No.
Dr. Cruz Flores?
Yes.
Dr. Lewis?
No, because I was interpreting this as this being a mandatory element.
Okay, Dr. Malkus?
Yes.
Dr. Ollendorf?
No.
Dr. Pope?
Yes.
Dr. Saliv?
Yes.
Dr. Jan?
Yes.
Dr. Listig?
Yes.
Dr. Carpenter?
No mandatory element issue.
I didn't hear what you said.
No, and for the same reason, as a mandatory element, I'm saying no.
Okay. Dr. Gaines?
Yes, and I also considered a switch to be a possible similar variable.
Okay, Dr. Sarte?
Yes.
Okay, and all right, on to the third bullet. Type of depressive episode, parentheses, unipolar, bipolar, psychotic, atypical, or other. Oh, interesting. Okay, Dr. Cuyjet.
Yes.
Dr. Burke.
Yes.
Dr. Cruz Flores.
Yes.
Dr. Lewis.
Yes, with the intent that it simply means that this must be incorporated into the definition.
Dr. Malkus.
Yes.
Dr. Ollendorf.
Yes, what Dr. Lewis said.
Dr. Pope.
Yes.
Dr. Saliv.
No, I don't think it's always necessary.
Okay. Dr. Yan.
Yes.
Dr. Listig.
Yes.
Dr. Carpenter.
Yes.
Dr. Games.
Yes.
Dr. Sarate.
Yes.
Okay, and let me pause for a second. The editorial comments are extremely valuable. They are not required. But if I am trying to move us through, but in no way am I asking you to hurry on your editorial comments. So Dr. Lewis had a comment that I considered relevant. Take your time to explain what you think so that we can get it on the record. You do not feel rushed by simply the speed with which I'm calling you, okay? Is my way of saying that, okay? Next bullet. The use of non-pharmacological treatments such as ECT. Dr. Cuyjet.
No, I don't feel that needs to be a requirement to define clinical research in TRD.
Dr. Burke.
No.
Dr. Cruz Flores.
Yes, to the extent that they can be added as an alternative, as a may in the definition.
Dr. Lewis.
No, because I don't believe it should be a required element.
Dr. Malkus.
I say no for the same reason as Dr. Lewis.
Dr. Ollendorf.
I say yes because it can be a variant of a definition in certain settings.
Dr. Pope.
No, potentially relevant, but not essentially required.
Dr. Saliv.
No.
Dr. Yan.
No.
Dr. Listig.
No, not as a requirement, but again, it should be considered as an option.
Dr. Carpenter.
No.
Dr. Gaines.
No, it should not be a requirement. However, in a trial, if someone came in having failed ECT treatment, we would likely consider them to be treatment resistant.
Dr. Sarate.
No, and the same reason as my colleague here.
Okay, I'm going to pause again. I'm actually hearing something fairly consistent, which is it is one of several alternative paths to the definition. Another way of saying it is you would not consider it an exclusionary criteria to have failed at ECT. Is that fair?
Yes. Yes.
Okay. All right. The use of psychotherapy. Dr. Cuyjet?
Yes.
Dr. Burke?
No.
Dr. Cruz Flores?
Yes.
Dr. Lewis?
No, because I would not want it to be a required element.
Dr. Malkus?
Yes, because I think it should be a required element.
Dr. Ollendorf?
Yes, for the same reasons I gave for ECT.
Dr. Pope?
No.
Dr. Saliv?
No, not required.
Dr. Yan?
Yes.
Dr. Listig?
No, agree with Dr. Lewis.
Dr. Carpenter?
No, but also because there'll be many settings you want to recruit from where psychotherapy is simply not being given. I would not want to exclude people.
Dr. Gaines?
Yes, it's an important element, but not having it should not exclude someone from the definition.
I'm sorry, we can't hear you. Can you guys please speak into the mic?
Yes, because it's a consideration in treatment-resistant depression, but it's not something that, should someone not have it, that they would not be defined as having TRD.
Dr. Sarate?
Yes, I believe a good therapist can give a good trial, should be considered as adequate for considering TRD.
Score changes on standardized and validated depression rating instruments, for example, the Hamilton Depression Rating Scale.
I apologize, excuse me. Could all the panel members, can you please speak directly into the mic because people on the web are unable to hear you as well as our transcriptionist? Thank you.
Dr. Cuyjet?
Yes.
Dr. Burke?
Yeah, this is one of the critical elements in defining characteristics.
Okay. Dr. Cruz Flores, please speak into your microphone.
Yes.
Dr. Lewis?
Yes.
Dr. Malkus?
Yes.
Dr. Ollendorf?
Yes.
Dr. Pope?
Yes.
Dr. Saliv?
Yes, I think it's a severity measure.
Dr. Yan?
Yes.
Dr. Listig?
Yes.
Dr. Carpenter?
I'm voting yes because I'm ignoring the change. I don't know what it means for change, but if it means hitting a severity criteria, then it's yes.
Right, and we discussed this, and change consistent, just the notion of having one of the scales as a defining characteristic was what we zeroed in on. So, Dr. Gaines.
Yes, and I specifically would want to identify the importance of using remission as one of those measures.
Dr. Sarate.
Yes.
Remember, we've broken the next one, so it's suicidal ideation is the next one. Dr. Cuyjet.
No.
Dr. Burke.
No.
Dr. Cruz Flores.
No.
Dr. Lewis.
No.
Dr. Melkus.
No.
Dr. Ollendorf.
No.
Dr. Pope.
No.
Dr. Saliv.
No.
Dr. Jan.
No.
Dr. Listig.
No.
Dr. Carpenter.
No.
Dr. Gaines.
No.
Dr. Sarate.
No.
The next bullet, and on your score sheet, it no longer reads other. I hope it should now read suicide attempts. And so, can you vote on that? Suicide attempts, please.
No.
That was Dr. Cuyjet. Dr. Burke?
No.
Dr. Cruz Flores?
No.
Dr. Lewis?
No.
Dr. Melkus?
No.
Where are we? Dr. Ollendorf?
No.
Dr. Pope?
No.
Dr. Saliv?
No.
Dr. Jan?
No.
Dr. Listig?
No.
Dr. Carpenter?
No.
Dr. Gaines?
No.
Dr. Sarate?
No.
Okay. The next question is number 3. You go back to your other pads for voting. How confident are you that this definition, meaning, hold on a second. What? No, I know that, but the definition that they're envisioning and the definition that's going to use in clinical practice or in clinical research.
I guess it's the definition that they used in question 1, so they said that there was a standard definition.
Okay. All right, I'm going to propose this, but I want to discuss this. We're going to take a small pause here because of the pronoun, this. How confident are you that this definition can be applied to Medicare beneficiaries? I've already clarified that this question refers to the application in clinical practice, but I'm hung up, and maybe it's just the hour. I'm hung up on whether or not this definition refers to the standard definition of TRD in question 1, or the definition as constructed through the integration of the responses to question 2, which would be some definition that had important defining characteristics. Maybe Dr. Listig is about to resolve this for us.
Well, no, I think the question there starts about you're basing what happened in question number 1. So I would read this as saying, referring back to 1 and not thinking about question 2.
It has to be 1.
Good, okay. Is there any disagreement on that? Okay, so question 3, you are answering a question regarding the application of the standard definition of TRD as in question 1. How confident are you that this definition, that is the standard definition of TRD, can be applied to Medicare beneficiaries with your buttons for question point A in primary care settings? Two of you have not voted yet. Oh, no, there we go. All right, 2.66. I'm going to poll you for your votes, and again, if you have comments, that's great. Dr. Cuyjet?
I voted a 4.
Dr. Burke?
2, I didn't think this would give sufficient guidance to primary care physicians.
Dr. Cruz Flores?
2.
Dr. Lewis?
I voted 4, and I believe that there is a definition that could be applied in this setting.
Dr. Melkus?
3, I'm not sure that it can be given the constraints of time and resources.
Dr. Ollendorf?
I voted 1 because of the reported high rates of pseudo-resistance in this population, and because the instruments that would be used to measure response or remission are not necessarily applicable to primary care practice.
Dr. Pope?
3.
Dr. Saliv?
3.
Dr. Yan?
2.
Dr. Sorry?
I just have a comment that.
Can you speak into the microphone, please? Yes.
For Lulu areas and primary setting might be because there are not many general psychiatrist clinics that the patients can go. So primary care setting maybe for Lulu patients may be able to access for them.
I take the term primary care to refer to non-psychiatric physicians, family practitioners, internal medicine doctors, and not general psychiatrists, which I think is addressed by bullet B, or point B. Does that help you?
Well, if not consider Lulu area, I would vote 1, but I voted 2 is because of consider Lulu area, because think about Lulu area when they're looking at the primary care doctor is the first line physician, they will provide initial assessment or something. Is that?
Okay, I understand that distinction. Okay. Dr. Listig?
2, I think there'd be challenges in applying it in the primary care setting.
Dr. Carpenter?
I did a 4, not because they're not challenges, but because I think the construct can be understood. I think it has to be applied, and I think perfect would be the enemy of the good. So I'm not too concerned if sometimes somebody's only slightly resistant and gets qualified as that because it's leading to treatment modalities.
Right, and to echo what you've said, it does say can be applied, not is currently applied. Dr. Gaines?
I gave it a 4, and with 2 points. 1, I think the increasing use of the electronic health record would help that dosing question get answered. And then the second point is just to clarify that the tools to identify whether someone has TRD in terms of depression measures, they have been validated and used well in primary care settings.
Dr. Sarate?
3, but there would need to be educational efforts.
Okay. Thank you. Can I ask you to vote on the next bullet? Same question, in general psychiatric settings. Can I ask you to press your vote again? We're missing somebody. Here we go. Okay, 3.88, or 3.89. Dr. Cuyjet?
Again, I voted 4. And just to comment on the first one, I mean, we're trying to direct care to primary care and having a simple standard so that they know when patients meet criteria and need referral for further evaluation or treatment is appropriate, regardless of time constraints and other issues.
Dr. Burke?
I gave it a 3 because I still think that the definition is too ambiguous, vague to be readily applied.
Dr. Cruz Flores?
4.
Dr. Lewis?
5.
Dr. Melkus?
5.
Dr. Ollendorf?
3.
Dr. Pope?
4.
Dr. Saliv?
3.
Dr. Yan?
4.
Dr. Listig?
4.
Dr. Carpenter?
5.
Dr. Gaines?
5.
Dr. Sarate?
4.
Last bullet, 3, in specialty psychiatric settings. Please press your buttons. Can I ask you to vote again? We were missing several. We're still missing somebody. Sometimes it doesn't register, in which case you can't vote twice, so you can try again.
It's the green light. Try again.
There we go. Okay, 4.8. Dr. Cuyjet?
4.
Dr. Burke?
4.
Dr. Cruz Flores?
5.
Dr. Lewis?
5.
Dr. Melkus?
5.
Dr. Ollendorf?
5.
Dr. Pope?
5.
Dr. Saliv?
5.
Dr. Yan?
5.
Dr. Listig?
5.
Dr. Carpenter?
5.
Dr. Gaines?
5.
Dr. Sarate?
4.
Okay, thank you. We're on to question 4. How confident are you that each of the below is a reliable, valid, and meaningful health outcome for Medicare beneficiaries in a trial of an intervention for treatment-related depression. So we're going to vote on these separately. 4A, improvement or decline in depression as measured by depression scales. And please vote with your pads. .4. Dr. Cuyjet?
I voted 4.
Dr. Burke?
5.
Dr. Cruz Flores?
3.
Dr. Lewis?
5.
Dr. Melkus?
5.
Dr. Ollendorf?
5, assuming, sorry.
Please.
Just assuming that this includes outcomes meeting remission and/or response thresholds.
Dr. Pope?
3.
Dr. Saliv?
5.
Dr. Yan?
5.
Dr. Listig?
5.
Dr. Carpenter?
5.
Dr. Gaines?
5.
Dr. Sarte?
5.
Next bullet, improvement or decline in function. Please vote. Somebody's keypad is causing us trouble. And again, can I ask everyone to vote again to... .6. Dr. Cuyjet?
4 again.
Dr. Burke?
5.
Dr. Cruz Flores?
5.
Dr. Lewis?
4.
Dr. Melkus?
5.
Dr. Ollendorf?
5.
Dr. Pope?
5.
Dr. Saliv?
5.
Dr. Yan?
3.
Dr. Listig?
4.
Dr. Carpenter?
4.
Dr. Gaines?
4. It's challenging to measure.
Dr. Sarte?
4.
Next bullet, improvement or decline in quality of life. Please vote with your pads, and I'll just ask you preemptively to vote multiple times. We have a couple of Chicago natives I know here. It worked. 4.6. Awesome. Dr. Cuyjet?
4.
Dr. Burke?
5.
Dr. Cruz Flores?
5.
Dr. Lewis?
4.
Dr. Melkus?
5.
Dr. Ollendorf?
5.
Dr. Pope?
4.
Dr. Saliv?
5.
Dr. Yan?
4.
Dr. Listig?
4.
Dr. Carpenter?
4.
Dr. Gaines?
4.
Dr. Sarte?
4.
Decrease, and as I noted before, should actually be phrased in a bi-directional way, but it is currently phrased as decrease in suicidal ideation. Please vote multiple times. .1. Dr. Cuyjet?
I voted 3 on this one.
Dr. Burke?
4.
Dr. Cruz Flores?
3.
Dr. Lewis?
2. I was stuck on the meaningful term.
Dr. Melkus?
I voted 5 in that if there's a decrease in suicide ideation, that's a good thing. And if the people in the study had that, reported it as a history, that's how I interpreted it.
Oh. Hold on a second. Okay. I followed you. Thanks. Dr. Ollendorf?
I voted 2 because given that there are high rates of suicidal ideation outside of the TRD realm, I wasn't sure how meaningful this would be.
Dr. Pope?
1.
Dr. Saliv?
3.
Dr. Yan?
2, because this measure may not be available for everyone.
Dr. Listig?
4. If you can show it, it's very valuable, but I would put a caveat that I wouldn't make it a requirement that you would have to demonstrate this change.
Dr. Carpenter?
Well, I did a 3, partly because it's not applicable to many patients, but also because sometimes suicidal ideation increases with clinical improvement. So it's not an unequivocal bad sign in terms of therapeutic response.
Dr. Gaines?
5, whether it goes up or down, it's an important and clinical meaningful outcome.
Dr. Sarte?
4.
Okay, thank you. Decrease in suicidal attempts. And please, again, vote multiple times. 3.6, Dr. Cuyjet.
I voted for.
Okay, Dr. Burke?
5.
Dr. Cruz Flores?
3.
Dr. Lewis?
1, still concerns about the meaningfulness of it.
Okay, Dr. Melkus?
5 for the same reasons on the ideation.
Dr. Ollendorf?
4 if you can measure it.
Dr. Pope?
3.
Dr. Saliv?
3.
Dr. Yan?
2.
Dr. Listig?
4 for the same reasons as ideation.
Dr. Carpenter?
2, because it's such a rare phenomenon in the context of a clinical trial. I don't think it's very meaningful.
Dr. Gaines?
5 for the same reasons as ideation.
4. Okay, thank you. Dr. Sarta. Okay. It's fill in the blank time. Other. If you want to vote, you can. No, we're going to go on to the next question. Is there an endpoint or reliable, valid, and meaningful endpoint that we should have had on this list that's come up in the course of this context, this discussion, in which case I think we could fill in an other, but I don't want to vote on other without clear definition of what is meant. So I'm happy to pause here. Dr. Gaines, you look like you have something to say.
Yeah, one possibility might be some measure of sustained remission. We talked about the temporality piece, and that I know generated some discussion here, so that's one possibility.
You don't think that's subsumed in A?
Might be. No one had specifically mentioned it as a comment.
Based on qualitative description, the remission might be a more temporal.
Okay.
I don't think we need to vote on it. I guess we've now discussed how it's
Well,
something
we
to
could.
consider. And it
I'm
could be
happy
a
to
part of A.
fill it in as the answer and then vote on it if that's the one that's on the table. Dr. Saliv.
Safety is omitted.
Safety.
I
Okay.
was thinking about adherence. You know, if somebody takes their medication 100% versus 90% versus 80%, what's the dose effect? Is it the same if the people have good outcomes?
Okay.
Yeah, but this is an outcome. You're talking about the outcomes. It's not.
Yes, speak into your microphone, but Dr. Burke said we're talking about the outcome. The question is, how confident are you that each of the below is a reliable, valid, and meaningful health outcome? And so what's on the table now is duration of remission, safety of the medication, and adherence?
No, because that's not a health outcome. That's just a measure of no, the health
Okay.
outcome. It's not a health outcome.
Safety, not an outcome, is an outcome?
It's not a health outcome.
Dr. Ollendorf, you look like you want to say something?
I was going to ask if we could, the sustained remission one, if we could add relapse as the counterpart to it. So we talked about that as well today.
Okay, Dr. Lewis?
To pull those together, maybe it's time to relapse measured at like in a survival study so that it includes the censoring for patients not yet observed to be relapsed. That captures the time to event and captures the proportion that relapsed during the observation period. So the chair's
can we vote on
permission-
it?
So the chair's permission, F would be time to relapse.
And if I can put on my cardiology hat with heart failure and readmission rates, this is clearly analogous. You want patients to stay in remission, so time to relapse would be an important measure to capture.
From the experts in the room, is there a methodologic issue with that? Otherwise...
Scott Aronson, it's actually very easy because you've already done your outcomes measures, so all you need is that outcome measure over time. All you're looking at is to make sure that nobody has shown relapse over the course of time that your study lasts. So it's actually very related to your primary outcome measure. This is just duration of a positive outcome.
Okay, so let's vote. The bullet is time to relapse. And please vote multiple times. Could you vote again, please? I'm relieved it didn't get a 1 after all that. Okay, Dr. Cuyjet.
I think I'm stuck on 4.
Dr. Burke.
3.
Dr. Cruz Flores.
4.
Dr. Lewis?
4.
Dr. Melkus?
5.
Dr. Ollendorf?
5.
Dr. Pope?
3.
Dr. Saliv?
5.
Dr. Jan?
5.
Dr. Listig?
5.
Dr. Carpenter?
5.
Dr. Gaines?
5.
Dr. Sarate?
5.
Okay, hold on one second. The next thing we need to do is discuss the a priori parameters that define successful or failed treatment for those that got a score of 2.5 or more, which are the majority. We're going to go, I've only notated the last couple, so we're going to go from the bottom up. Time to relapse got a 4.2, so the question is, what are the a priori parameters that define... All right, I'm sorry. Let me pause. On the questions. All right, let me pause. On your pink sheet, you have the questions to the MEDCAC. I don't believe you have the discussion bullet that that follows this question. So, but what the discussion bullet asks us to do with relation to question 4 is for each of the characteristics that we gave a favorable score, the cutoff 2.5 or higher, we can discuss the a priori parameters, or the parameters that define successful treatment, or the opposite of which is failed treatment. So this does not need to be lengthy. Of course, it can be if needed, but to some extent, we're just seeking information on directionality and maybe some inclination on magnitude. So for example, on time to relapse, I'm allowed to weigh in here. The a priori parameter that defines successful or failed treatment would be a lengthening of the time to relapse, I would argue. And then there'd be other measures such as remission rates or response rates that would also be important to mention. So that is the flavor of what we should discuss for each of these. Starting there, time to relapse. If there are dimensions that are important to capture. Dr. Gaines? Oh, no. Sorry, you faked me out. Dr. Lewis?
So if this was measured in a time to event study, the natural measure of the treatment effect would be the hazard ratio, and I would propose that a hazard ratio of 1 point, actually I have to do it the other direction, it seems to me, 2/3, which would be a lengthening of time of 1.5 or greater, would be a clinically meaningful difference.
Okay. Other comments on time to relapse?
I'd echo Dr. Lewis's comments and also add that using a cost proportional hazards model or other multivariate design, there'd be the ability to control for between group differences as well.
Thank you. Dr. Burke?
I think these are literature dependent, and I think one has to go to the literature in order to answer these.
Okay. Dr. Jan?
Time to relax is good outcome. The only concern is that the study needs to have a longer duration in order to have statistical power. If the event rate, incidence rate is lower, then you will have to have a very large study in order to find a significant difference.
Right. Well,
As
two
compared
things
to other
influence. First of
outcomes.
all, is the number of people who get in remission in the first place affects that measure.
So it really depends on the effect size.
What about decrease in suicidal attempts? There was mixed. Do you have all the votes?
They're all above 2.5.
They all are. Okay, good. All right. Decrease in suicidal attempts, the parameters that define successful or failed treatment.
Carpenter. So that's problematic because most people in trials, when would they have had an attempt? So for most, it might be 0, and if it's not 0, then it's going to be a question of what time frame are you looking at, the last 10 years, 5 years? And then virtually nobody is going to attempt it in the course of the trial. So I don't see how you turn that into a meaningful criteria.
That's useful feedback. What about decrease in suicidal ideation?
Same problem. Temporal duration. How long are you looking at? Just in the study? You say where it's very infrequent. If you look at it just in the study, it's very infrequent, then your confidence interval is going to be huge.
And just a reminder that sometimes you get suicidal ideation associated with improvement in depression.
Changes in quality of life. I believe there's a clinically meaningful difference in quality of life scores, isn't there?
It's well known, and I think there's a lot of questions in the SF-36 related to mood, and those are where the action is in this case.
And improvement or decline in function, I think same there, right? That those are. And what about A, improvement or decline in depression as measured by depression scales? Is there a clinically meaningful?
It's defined in the scales.
You have to talk in the microphone.
It's defined in the scales what's clinically meaningful. They actually have the criteria for clinically meaningful.
And a reminder that changes in score above certain thresholds represent remission and/or response on these scales as well. So those can be separate measures that are driven by the same thing.
Yeah. And they're actually in the measures themselves, these criteria.
And you can look at both remission as well as sustained remission.
Is sustained remission the same as time to relapse?
Yes.
Okay. We're going to move on to question 5, barring further comments, and I appreciate everyone's stamina on this. How confident are you that the strategies below, when applied to Medicare beneficiaries, represent meaningful and realistic study designs and research investigations performed to evaluate interventions for TRD? Again, voting using your keypad. The first option is randomized, sham-controlled, double-blinded study. Can you vote again, please? This is, oh, there we go. 4.8. Dr. Cuyjet?
4.
Dr. Burke?
5.
Dr. Cruz Flores?
4.
Dr. Lewis?
5.
Dr. Melkus?
5.
Dr. Ohlendorf?
5.
Dr. Pope?
5.
Dr. Saliv?
5.
Dr. Jan?
5.
Dr. Listig?
4.
Dr. Carpenter?
4.
Dr. Gaines?
5.
Dr. Sarte?
5.
B, randomized sham-controlled single-blinded study, which I take to be that the subject is blinded but the investigator is not. Please vote. Is it not reset?
How do you move this forward?
Oh, there we go. Okay, please vote. Sorry. Did Dr. Melkus's button get pressed?
Yes.
Okay, so we're still missing, oh no, 3.7. Dr. Melkus, thank you. Dr. Jan, thank you. I think you're, okay. Dr. Cuyjet?
I voted 3. There's potential for bias.
Dr. Burke?
2.
Dr. Cruz Flores?
4.
Dr. Lewis?
2.
What did Dr. Melkus vote?
4.
Dr. Ohlendorf?
4.
Dr. Pope?
4.
Dr. Saliv?
5.
Dr. Jan's vote?
5.
Dr. Listig?
4.
Dr. Carpenter?
3.
Dr. Gaines?
5 with an appreciation that in some ways that reflects more of what happens in real world settings.
Dr. Sarte?
4.
Great. Randomized controlled unblinded study. Please vote again. Okay, 2.4. Dr. Cuyjet?
I voted 1.
Wow.
No, let's randomize. No, we're going to randomize sham control C. C is 1.
C. Yes.
C is 1.
Okay. Dr. Burke?
2.
Dr. Cruz Flores?
3.
Dr. Lewis?
2.
Dr. Melkus?
4.
Dr. Ohlendorf?
1.
Dr. Pope?
3.
Dr. Saliv?
3.
Dr. Jan?
3.
Dr. Listig?
put a 5 for this, and actually, because I'm looking at the fact this is the first one that is not controlling against a sham. It actually has the possibility for an active comparator, which I think is very relevant here, and also the fact that we're looking for both meaningful and realistic in terms of being able to be executed.
Thank you for that. Dr. Carpenter?
2.
Dr. Gaines?
3, the important key here, actually both patient and clinician could be unblinded, but as long as the research outcome assessor was blinded, it would give you a pretty decent measure.
Dr. Sarate?
2.
Thank you. Randomized crossover design.
It's unblinded.
Unblinded.
The next 3 are
If it does not, right, all of the remaining ones are unblinded to both participant and researcher.
Someone else.
Please vote again. Oh, there we go. 2.3, Dr. Cuyjet?
3.
Dr. Burke?
Yeah, 2, and the only reason I gave him that was because of the randomization. The unblinding is a severe weakness.
Dr. Cruz Flores?
3.
Dr. Lewis?
2.
Dr. Melkus?
3.
Dr. Ohlendorf?
1, I think I'm challenged by all of the unblinded designs because the measures of interest are self-reported or clinician measured.
Dr. Pope?
2.
Dr. Saliv?
2.
Dr. Yan?
3.
Dr. Listig?
I'm going with 4 here because I'm thinking both for the fact that the crossover allows you to do within patient comparisons, which is very important within a heterogeneous population, and for the concept that was raised earlier that just because the patient and the physician are unblinded does not mean that the assessor cannot be blinded to the status, and so you can still it's possible to get good information out of it.
Dr. Carpenter?
2 comments. One is that I think in this population it's going to be extremely difficult to have the person have the same starting point after the crossover as they did in the beginning, so it's a real compromised design. And just a comment on all my ratings, which are a point lower than I would give otherwise because of the problem of generalizing from the clinical trials to the real-world population where substance abuse and lots of other things confound.
Thank you. Dr. Gaines?
2.
Dr. Sarate?
2.
Non-randomized crossover study. Can you vote again, please? There we go. 1.7. Dr. Cuyjet?
2.
Dr. Cruz Flores? Dr. Burke, I'm sorry.
All right. 1.
Dr. Cruz Flores?
2.
Dr. Lewis?
1.
Dr. Melkus?
3.
Dr. Ohlendorf?
1 for the same reasons as before.
Dr. Pope?
2.
Dr. Saliv?
1.
Dr. Yan?
2.
Dr. Listig?
2, and I'll point out that sometimes we can look at this as an addition to existing evidence. It might be a different answer if this is going to be our sole source of evidence for the treatment.
Dr. Carpenter?
1.
Dr. Gaines?
2.
Dr. Sarate?
2.
Pre-post study design. Yeah, it's got to be reset. Hold on. Okay, please vote now on pre-post study design. That was quick. 1.4. Dr. Cuyjet?
Yeah, 2. The unblinded studies, there's no way to control for placebo effect, so I don't know how reliable the data is.
Dr. Burke?
1.
Dr. Cruz Flores?
2.
Dr. Lewis?
1.
Dr. Melkus?
3.
Dr. Ohlendorf?
1.
Dr. Pope?
1.
Dr. Saliv?
1.
Dr. Yan?
1.
Dr. Listig?
2.
Dr. Carpenter?
2.
Dr. Gaines?
1.
Dr. Sarate?
2.
Okay, I'm going to take the prerogative of the chair to delete other because 2 of our panel members are no longer here, so we can't elicit their votes or views on it. And I believe that is it, except for I'm supposed to say something, and Tamara, you're supposed to say something too. I go first? Okay. First of all, thank you to the speakers and the other attendees today for this. We all know it's a long day, but we will be out in time for tomorrow's session at 1 o'clock. And appreciate that it is the very vagaries of everything we've discussed today that are the purpose of having these panels. We don't have MEDCACs when everything is nicely served up around the evidence or things are clear in either direction. So I also want to thank my panelists for putting up with me as a chair and for this discussion and for the steady focus on trying to clarify things. So thank you all very much.
And I just want to reiterate what Dr. Bach has just said. Thank you, panelists. It was a long day, but it was a very good day for us. This is an extremely important topic for the Medicare population. And this is a topic that we have been struggling with, so all of you have really helped us decide what our next steps forward might be. So again, thank you for your comments. Thank you, speakers invited, and and the public speakers as well. We really do appreciate that. And panel, thank you for your comments and your votes. We are going to be looking at the minutes closely, and again, we'll be deciding what to do next with what we did today. So thanks again.
All right. Good session. Do you want us to?